right, here is part 2. Let's get started where we can actually go through. All right, here we go. Fertilization takes place where? Use your clickers. Where does fertilization take place? And the clicker thing is over there, so point that way. Where does fertilization take place? All right. That's it. So we're just missing 1, 2, 3 people. All right. Fertilization actually takes place in the fallopian tubes. Why did I not go? All right. The correct answer is fallopian tubes. That's where fertilization takes place. What do the ovaries do? They produce the eggs. The eggs get spit out of the ovary, and it goes into the fallopian tube, and the sperm travels out through the vagina into the fallopian tubes, and that's where it gets fertilized at. Where does it attach at? In the uterus. Okay? What is considered the womb for the fertilized egg? What is considered the womb for the fertilized egg? The womb.
It's an interesting word when you say it.
The womb.
It's like the tomb.
Womb. All right, the correct answer is the uterus, also known as the baby house. Now, what is the fundus?
That thing you massage.
That is the top part of the uterus. And what can you do with the fundus after a baby's born?
Massage it.
Why would you massage it?
To decrease vaginal hemorrhage.
To decrease vaginal hemorrhage. And vaginal hemorrhage is a blood loss over how much? 500 milliliters. All right, what serves as the birth canal? What serves as the birth canal? You are so smart.
D.
I would not want to take the off.
Yeah, what need?
The correct answer is the vagina. The vagina is the birth canal for the baby. What does the cervix do?
It's just the gate.
It's just the open door. Okay? Think of the cervix as an open door. It has to thin out, also known as a face, and it has to dilate, which means to open up. So you got to open that door, and then it's going to go down the canal. Ma'am? That's the only thing it's there for. It helps to hold the baby in, and once the baby is ready to come out, that's when it will dilate and efface. Huh? Yes. Whenever you're in the hospital in labor, that's whenever the nurses and the doctors, they'll put on a sterile glove, and they'll feel inside to see how open the cervix is. And it can go from a 1 or 2. Think about this top of the water bottle. I'm going to use your water bottle. This top of the water bottle. How many fingers do you think you can get in here? 1, maybe 1.5. Don't know how small your fingers are. Maybe 2.
Yeah.
Okay.
Yeah, no.
Knew this was going to be an interesting day with y'all. You can put about 1.5 to 2 fingers in here. And what that means is that that person's dilated about 1.5 to 2 centimeters. All right. What about this Chick-fil-A cup? I could probably put. Yeah, you can put everything pretty much in here. My whole hand can fit in here, and probably about 3 more fingers. So how many do you think that is? What's 5 plus 3? They're about 8%. All right. Do you see how tall this cap is? See how thick it is? See how thin the lid to this is? That's the cervix dilating and effacing. Effacing means it's thinning out. So it's going from a thick, small object to a thin, wide open object. Okay? That good? You have to be this about 8. 10 would be that.
That's when they're screaming.
All right, and that's 10. You got to think, how big is a baby's head? That's a humongous child. Mine were tiny. Mine were 6'13" and 7'10".
So
They were tiny.
C-sections.
All right. External genitalia, we have the vulva, the labia. We've already talked about that. The Bartholin glands. What are the Bartholin glands for? Anybody know? Huh? Excess lubrication. It accesses the lubrication. It makes that area lubricated. If it gets clogged up, what's going to happen?
The doctor will pay
We should just
No, that's not going to
this whole
happen.
line.
They get clogged up from improper hygiene. A hair could get in the way, hair follicle. Mostly it's from improper hygiene, but it can be from constricted clothing, like people who like wear really tight clothes. It's too tight for their body type.
But you can't die from that, correct?
No. Well, it depends. If you don't get it taken care of, it can
Sure, you cover 'em
cause
over with a
sepsis.
sheet.
So if you have somebody complaining of vaginal pain, you look in that area and they've got this huge knot, it's probably a Bartholin gland cyst. And so that cyst is some kind of bacteria has gotten in that gland and caused it to swell and become abscessed.
I've seen this because this girl came in the emergency room saying that she found it when she was
Yeah, they come in all the time. It's one reason why I hated having the OB rooms when I worked in the ER is because either I would have some type of foreign body, I would have a Bartholin cyst, or just nasty STD drainage. We're going to talk about that soon. All right, what about a clitoris? Do we need to talk about that? Y'all good with that? Can't take anymore. All right, what part of the female anatomy is responsible for producing and secreting milk? The pancreas, really? Really? I almost smacked whoever that 9% is. The pancreas does not produce and secrete milk. What does the pancreas produce? While we're on this subject. Has alpha and beta cells and produces insulin and glucagon. All right, the mammary glands is what produces the milk and also can secrete it. All right, what about menstruation? What is that?
The worst time of the month.
And you just think it's bad for you? Please.
Yeah, I was going to say.
It is menstruation. How long does a cycle last? For most people, how long does a cycle last?
7 days.
Actually, the whole process is 28 days long. Okay? But the physical bleeding lasts anywhere from 3 to 7 days. Some people 10, some people 2 or 3. If those are the 2 to 3, they're really lucky. The 10 people, I feel really sorry for them. But a normal cycle usually lasts about 28 days. So the first 14 days is what? What happens in that first 14 days?
Your body
All right, the first day is your cycle itself starting, the period itself, the bleeding, and then 14 days later, what is the ovary doing? Ovulating. And what's that mean? It's getting the egg released. Think about it, an ovary. I didn't bring my marker up here, my pretty pink marker. This is your big ovary. You have thousands of little eggs in here, okay? Eggs just go around the ovary and get bigger and bigger and bigger and bigger and bigger until it's ready to blast out. And what's it going to blast out into? Into the fallopian tube, okay? Once they blast out of the blast out of the ovary and go into the fallopian tube, that's around day 14. Is this whenever women can get pregnant? Yes. Usually 14 days after their cycle is when they are most prone to getting pregnant. Now, how long does it take? How long does that last? What's that period?
3 days.
It's a period of about 3 days. But technically, the highest part is usually 2 to 4 hours. It's not very big at all. It's very small. We're just getting really lucky. Really lucky. All right, it does, let's see. Average menstrual flow is about 25 to 60 milliliters. For us girls, it seems like it's a lot more than that. But it really is only about 25 to 60 milliliters. Usually lasts typically 4 to 6 days. Onset of menses is usually between the ages of 12 and 13. You have some females who get it very early and some later on in life, later on in their teen years. Ends permanently at the average age of 47 years. That's whenever hormone production decreases. Women start getting mustaches and sagging in places they don't need to, and voice gets a little bit deeper because they're not producing enough estrogen and progesterone to keep them looking feminine. Just awful. Menstruation does occur in two phases: the follicular phase, which eggs are ready to be released, which is that 1 to 13 days, which is when they're going around the ovary, getting bigger and bigger and bigger until they are ready to be blasted out. And the luteal phase lasts 14 to 28 days. And at the end of that 28 days, that's when, if the egg does not get fertilized, what happens to it? Everything gets flushed out. Well, in this 14 to 28 days, what's the uterus doing? It's thickening, and it's getting ready to house the baby, right? So when that egg gets down to the uterus, it's either ready to attach it and make a baby, or it's ready to slough everything off. So at the 28-day mark, that's whenever the lining of the uterus and everything sloughs out, and the bleeding starts. This picture's a lot better than my picture that I drew on the board. What you think? You like mine? It does, doesn't it? With lots of eyes.
Long chapter.
All right, now once the egg is blasted out of the ovary and goes in the fallopian tube to be fertilized, the housing of the ovary, or excuse me, housing of the egg comes back down to this side and turns into a corpus luteum. What is that? What does this do? If that egg gets fertilized in the fallopian tube and attaches to the uterus, what is the life house for the baby? The placenta. Does that automatically form, or does that take some time? It takes some time, right? The corpus luteum is actually what gives the baby its nutrients and works like the placenta does until the placenta can be formed. The placenta is an organ, so it takes a couple of days for it to get formed. I think it's like 6 or 7 days. I can't remember what your book says. I think we talk about that in OB here in just a few minutes. I can't remember exactly what it says. But while that placenta is developing, the corpus luteum is what is giving the baby its nutrients and working like the placenta does. It just dies. It disintegrates. And the whole process, as you can see, starts back over at ground zero. Poor little eggs. Poor little baby eggs. All right, hormones are released from the hypothalamus and the anterior pituitary are what control ovulation and the menses. So the hormones are released, they go to the ovaries and say, hey, get these eggs working around, make them bigger and bigger and bigger, get them ready to house a baby, and throw them out. All right? If that's not working, we don't house a baby, then we need to start over. Start the process over again. Okay? Under the influence of the ovarian hormones, lining of the uterus goes through 2 phases. The proliferative phase, I give up, and the secretory phase. As you can see, this is the proliferatory phase. Blood and everything will start to accumulate. They will have the tissue lining, everything will get sloughed off, and that's when your menstruation will start. Basically, just talked about all of this. Secretory phase begins after ovulation. I mean, it's just the same thing. It's proliferation as the uterus and everything is getting ready, and the secretory phase, everything's getting secreted out. In absence of fertilization, the ovum can survive for only 6 to 24 hours. So it usually takes place on day 28 of the cycle, about 14 days after ovulation. The oocyte is capable of being fertilized for up to 24 hours after ovulation. Highest mark's usually about 3 to 4 hours. So it can be fertilized up to 24 hours. How long can a sperm survive? It can survive for days. I think like 6 days, 6 or 7 days. What could happen to the menstrual cycle if the hormonal balance is off? So if you weren't getting adequate estrogen and progesterone and those hormones are not working like they're supposed to, what could happen to your cycle? You could not have it, or what else? It could last for a long time. You could be late or early, completely irregular. Not everybody's on that 28 cycle. People who take birth control, their stuff's regulated by more hormones, so they're more likely to be on a regulatory cycle, usually a 28-day cycle. All right, let's see. We're going to talk about some gynecological emergencies. The first one is severe abdominal pain. You have somebody who's complaining of severe abdominal pain. 18-year-old female complaining of severe abdominal pain. What are all the things running through your mind that it could be?
Ectopic pregnancy.
Topic pregnancy. What else? Pregnancy in general. Miscarriage. Like what? Just abdominal cramping. Maybe an ovarian cyst. Abruptio. Endometriosis. What are some non-gynecological problems that it could be? Huh? Appendix? Gas. Constipation. Have you ever had gas? That hurts, doesn't it? Almost as bad as anything else. Especially if you don't let it out. Alright, and that does not give y'all free reign. Go outside, please. Please, please, please. Can be caused by chronic infection involving the uterus, ovaries, fallopian tubes, and adjacent structures. So anything in that physical area can cause a gynecological emergency causing severe abdominal pain. Now, not every patient that you go to that complains of abdominal pain is pregnant. But that is one of the questions that you need to ask, especially if they are in that childbearing age. Ask if there's any way they can be pregnant. What if it's a 14-year-old girl complaining of abdominal pain? How would you handle that situation?
Ron, how would you handle that?
12 I would just ask if you're sick.
I'm going to have to hear this story.
It was a joke. Apparently it's
You
going.
made a comment about a 14-year-old girl in the last class period.
Mike Harper was. I shouldn't say
You said
that.
Mike Harper, that's enough.
I shouldn't say that.
But if you have somebody who is an adolescent and they are complaining of abdominal pain, would you ask them in the presence of their parents or with their parents gone? Try to get someone to take their parents away to ask them some questions. And you want the same sex, like you want a female medic as best as possible to be the one to ask them the questions.
Because John Tarman's scared of it.
All right? Infection of the cervix, uterus, fallopian tubes, and ovaries and their supporting structures, and is caused by an STD. So what is known as an infection of the cervix, the uterus, the fallopian tubes, and the ovaries, and all the surrounding structures that are caused by an STD? That's a mouthful. Pretty much everything below the waist is messed up. And it's caused by an STD.
Is that when they
I
come?
should say it's caused by a non-treated STD.
Is that when they come in with their knees together?
Holding
That
it together.
well,
The shuffle. All right, just come on, that needs to answer. I'm only missing 2 people today. And there's 28 of y'all, so it should say 26 responsible down there.
that's what a PID
All right. So is it pelvic inflammatory disease or vaginitis?
Public inflammatory disease.
Pelvic inflammatory disease. Who wants to do the PID shuffle? What does that look like? Come on, Ryan.
I'm not doing
You can do it.
But it's funny.
How do they look?
They look like.
What do they look like?
They look like a
Look
duck.
like this? They do look like little old ladies with helmets.
They just.
Walking around. They can't hardly walk. Moving this area down here is very painful. They cannot move hardly at all. What is vaginitis?
Inflammation.
Inflammation of the vagina can be caused by a bacterial infection. It can be caused by an STD. It's usually treated with what? Antibiotics. And not constantly be treated with like diflucan. So it can be caused by yeast.
Oh.
All right, so pelvic inflammatory disease is everything in that area is messed up because they've had an STD that they haven't gotten treated. How do you think they're going to treat this?
So,
Mm-hmm. Pretty strong antibiotics, mostly IV antibiotics. What are you going to do for them as a paramedic?
consult them. Tell them it'll be okay.
Emotional support is very good with a straight face. Emotional support. What else? Comfort measures, position of comfort, transport them. They need an IV.
Sure.
I mean, yeah, you can go ahead and give them an IV. This apparently is very painful. I personally have never had it, but I know patients that come in, they look like they are in tremendous pain. When you see guys who come in with kidney stones, have their doubled over and can barely walk, that's what a female with PID looks like. And they're in about the same amount of pain. And it's our job to not be judgmental. All right, pelvic inflammatory disease. We already talked about this. They'll have low-grade fever, vaginal discharge. What kind of vaginal discharge do you think they're going to have?
Gross.
A very foul, yellow, brown, green
Oh.
discharge. Somebody say this word.
Dysphoria.
Yeah, I can't do that word either. But it's pain with sexual intercourse.
Ah, terrible
Can also infect the cervix. Of course, we already talked about that. Inflammation often follows onset of menstrual bleeding by 7 to 10 days. Reproductive organs are very vulnerable to bacterial infection. If that bacterial infection gets up into the reproductive organs, up into the ovaries, can it make it infertile? Yes, it can. It can cause a lot of damage that's irreversible. It's often accompanied by pain on ambulation, which is why they kind of tilt over and they keep their legs and stuff together and they kind of do that waddle, what we call the PID shuffle. Consequences. We are talking about infertility. They can be at risk for ectopic pregnancies.
What's so funny, Ron?
Why would they be at risk for ectopic pregnancy? Infection can cause some scarring in that area. All right, what else? Ovarian abscesses. Can you imagine having an ovarian abscess? Whew.
No, I can't.
Nope. You can't either? In severe cases, reproductive organs may need to be surgically removed. That's awful. Definitive treatment is antibiotic therapy. Pre-hospital care is mainly supportive. We already talked about a Bartholin's abscess. Bartholin glands are what help with lubrication. They get clogged or blocked by bacteria or infection or a hair follicle. Can take several days to weeks to develop. Cause lots of pain. Causes a large red swollen mass to come up on the labia. What do you think these patients are going to have done in the hospital? You're going to have an I&D, also known as an incision and drainage. And these people scream bloody murder. I cannot imagine what that would feel like. It'd be somebody cutting your scrotum. How would that feel?
Oh my God.
Put in perspective for you two, okay? Any activity, by the way, that puts pressure on this is going to cause a lot of pain. All right? You can imagine you're walking. I mean, when you're walking, that area does move. So. Treatment, they're going to need biopsy to rule out any malignancy. Most of it's caused from staph infection, which we all have staph on our skin. That's why you don't pick at your sores and things like that because you don't want things to get infected. They're going to have antibiotics. Sometimes they might have to have surgery. A lot of times in the hospital setting, especially in the ER, when they open this abscess, they'll put what we call a, my mind starts with a W, can't think of it. But anyway, you know the little ear tubes kids get? Those little bitty tubes, they're about like that big. It goes in their ears. They put these little bitty tubes, drainage tube, in this area to help it drain and get all the infection out. All right, vaginitis, what I talked about is inflammation of the vagina. Can occur in young girls and women of all ages. People who douche, this can cause problems. STDs, bacterial infections, improper hygiene, also can be caused by yeast. So there's a lot of different things that can cause it. And the main treatment for it is antibiotics or antifungals. There's parasites too. It's kind of gross. I should have done this right before lunch, shouldn't I?
Oh.
They often complain of irritation and itching in the genital area. What else complains of irritation and itching? Yeast infection. It pretty much mimics a yeast infection. They're going to have a white, chunky discharge. They're going to have pain, itching, inflammation.
That's some trichomonas. That's some good stuff. Penicillin forever. Keep it together, Brandon. Keep it together.
Randy, explain yourself.
She's crying.
Y'all are making me look like a really bad teacher. Quit. If you laugh so hard, cry.
And then you're recording this too.
Okay.
What were we talking about?
They can be treated with antibiotics, antifungals, also good hygiene. Especially for some of your patients who are not medically inclined or your older patient, they tend to do that wiping motion from back to front. You imagine wiping from the anus to the vagina is going to spread a lot of bacteria. So instructing them on how to properly wipe and care for themselves is part of education they need to know. Yes, ma'am.
It said it can be transferred between partners, so like, what would guys have?
Trichomonas.
They would get, if it's caused by an STD, and they would get it. Like, guys really don't get yeast infection.
Thank God.
I mean, they can, because yeast, where does yeast grow?
Inside.
Warm, wet, moist places, okay? The penis can be a warm, wet, moist place. So vagina,
She said can be.
Yeast can grow in those areas, which, I mean, you're not going to, a normal person's not going to have intercourse whenever they have discharge, I would hope. But you do have those people who are very nasty that would do things like that. But it can transfer, like they could get a yeast infection in that area if it's caused by yeast, or if it's caused by bacteria, or if it's caused by some type of STD, it can transfer to the male patient. Now your male patients, when they have STDs, they don't really show signs and symptoms very much, like females do, right? They'll usually have pain on urination. That's one of their biggest signs, is they'll hurt when they pee. That's about it. Or hurt when they secrete other things. Alright, what's a ruptured ovarian cyst? Major pain. Alright, well when these eggs are rolling around in here and getting ready to be exploded out, Sometimes you can get a cyst that grows on the ovary as well. And it can be a fluid-filled cyst with blood, regular clear fluid. And it can happen every time you ovulate, which can be horribly painful. And a lot of patients who have this have to be on birth control to help suppress these. But it is a cyst that does grow on the ovary. And if it ruptures, and all of them do rupture, especially if you have one that comes on every cycle that you have, it grows and grows and grows and grows and grows until it ruptures. It can cause problems like you can have abdominal pain, you can have leakage of fluid. They can cause you to become infertile. They can cause a lot of abdominal pain. And a lot of times, people who have them, especially reoccurrent cysts that get bigger and bigger and bigger, when they do rupture, they can do damage to the ovary, and the ovary has to be removed. Do you know what it's called to have an ovary removed? What that procedure is called? Oophorectomy. It's an oophorectomy. 2 O's. Isn't that weird? Kind of a funny word. Birth control helps to suppress the estrogen and progesterone in birth control. It's actually the progesterone helps to suppress these cysts to keep them from growing. It's a hormonal thing. They can. If you have too many that cause a lot of that rupture constantly, they can cause damage to the ovary. Typical what? They vary. It can be very small to several millimeters. Yeah. Cysts are more prone to rupture in the corpus luteum. Is the corpus luteum cyst? What is the corpus luteum? Talk about that. What was that? Provides nutrients for the baby. Once the ovary explodes that egg out into fallopian tubes, that little house right there is what goes around in the ovary and provides the nutrients, right? Turns into corpus luteum. That can also develop a cyst, which is one of the most common cysts that females get. Can result, like we said, in localized one lower quadrant abdominal pain. So if you have an 18-year-old female who's complaining of right lower quadrant pain and she's supposed to start within the next week, she could be at risk for an ovarian cyst. But if she's also having right lower quadrant pain, what else might she have? Appendicitis. What else? Ectopic pregnancy. This is the menstrual cramping. Is her cycle fixing to start? The ovarian cysts usually grow and they get very large at that 14-day mark in your cycle. So 14 to 28 days is when that cyst is going to rupture. That's where you're going to have the most amount of pain. Onset of pain is usually associated with any type of abdominal trauma, sexual intercourse, exercise, and that causes vigorous activity and cause you to have some pain.
That's like a genetic thing, an ovarian cyst, they get something like your ovaries or what causes this?
It can be a hormonal imbalance.
I mean, is it like every time?
I have ovarian cysts, and I get one every month. And I can feel it rupture. It usually happens about within like a week or two before my cycle is supposed to start. I will have one, and I can feel it. It hurts really bad, and then it will rupture, and I'll have a lot of pain, and then it goes away.
So you just don't do anything about it? Or?
I can take birth control, but since I'm a nurse, I don't.
My sister has them, but not every
I have them every month. And mine are hemorrhagic cysts, so they're big, huge cysts full of blood.
blood. Yeah. Hers the last one. Dr. Hogan said from the side of your natural
Yeah.
that it
They can be very, very, very painful. It's pretty uncomfortable when that time happens. And the only thing that they can do is, like I went to the doctor a few weeks ago about it because they were coming back because I got them really bad before I had Annabelle, and then they're back now since I've had her. And the only thing they can do is either give you birth control or take them out. And I'm too young to have my ovaries taken out. I don't want to go through menopause at 30.
Oh, I can't wait. I wish they'd take it out right now. I love that.
All right, what is an ovarian torsion?
Ooh, isn't that when they twist around themselves?
When they twist, yeah, they twist. Okay, you have you remember back to our picture earlier? We had the uterus right here. Then you had your fallopian tubes. And at the end of your fallopian tubes was your ovaries. Just like testicles can twist on themselves, the ovaries can twist on themselves right through here. All right, just like with testicular torsion, you've got inguinal area pain, scrotal pain. Females are going to have that pelvic pain, usually on one side or the other. It's the exact same thing as a testicular torsion. If it doesn't get relieved, what's going to happen to that ovary? It's going to die. It's like getting blood flow. It's going to die. The fifth most common gynecological surgical emergency. In my 9.5 years of being a nurse, I've never seen an ovarian torsion. I've seen a couple of testicular torsions, but never seen an ovarian torsion. Signs and symptoms are going to have a sudden onset of lower abdominal pain, usually on the right side. Why the right side is more prone, I'm not really quite sure. The right side is more prone to get twisted. I don't know if there's more tubing there or more, I don't know why it does that. They're going to have some nausea and vomiting. They can have a fever, which is usually a late sign. Often begins with exercise, which is kind of similar to testicular torsions, right? Testicular torsions usually happen when? Happens when 14-year-olds are in PE, running around and ain't got support, right? Testicular torsions usually happen to teenage boys who are running around gym class with no support. Like they're running around in a pair of boxers. Everything's just flopping. Pain can be described as a sharp stabbing pain. Physician care, what are you going to do as a paramedic? What's pre-hospital care?
Pain management.
Pain management, IV, fluids, rapid transport, position of comfort, emotional support. Which if your patient's complaining of right lower quadrant pain, they're doubled over in pain, you can't even touch them, you're probably thinking appendicitis or ectopic pregnancy. You're probably not thinking ovarian torsion.
But either way, we wouldn't even something like that.
In medical direction allows you to, you could. But most abdominal emergencies do not get any pain medicine at all.
Yeah.
They need fluids if they're hypotensive or tachycardic, which they're going to be tachycardic. If they're hypotensive, something's wrong, right? If they're hypotensive, what's going on with them? They're bleeding, and they're going into shock. I like saying that word. All right, in the hospital setting, they're going to get pain medicine, they're going to get fluids, and they're probably going to have surgery. Because it's not like they can untwist them on their own. Men in the scrotal area, those can be manually untwisted. Imagine how painful that might be.
God.
But females, you can't put your hand up in there and manually untwist an ovary. You have to have surgery. Y'all good? All right, what is cystitis?
Inflammation of the
Inflammation of the bladder. All right, where's your bladder at? Up here, right? Up here? All right, what's coming down from the bladder? Your ureters that go to your urethra. All right, you have bacteria that come up your urethra into your uterus, and into your bladder. What are you going to have? Cystitis. Bladder infection. All right. Anybody can get this. Males, females. Can be called. Females are more likely to get it due to not urinating after sex. That's how a lot of women get bladder infections, is because they don't urinate after sex. Because you got to think, having sex, where's your urethra? Right here. Where's your vagina? Right here. Things rubbing all up in that area. Bacteria going back and forth in your urethra.
So urinary tract infection
Can lead to a bladder infection, which is cystitis. So I tell you to pee after sex because it helps to push that bacteria out. Because your pee is sterile. Helps to push all that bacteria out. Guys, too. All right, signs and symptoms. They can have fever, chills, lower abdominal pain. Urine can be foul-smelling and also can contain blood. You've got inflammation of the bladder. The bladder is a muscle itself, right? It can hurt. You have that suprapubic pain. Burning upon urination. We already talked about causes. But another thing is a structural abnormality. This can cause problems in infants that are born with ureter problems. They can get bladder infections very easily. Also, patients who have indwelling catheters. You got to think that is a pathway for pathogens, right? Catheter that goes straight into the bladder. Pathway for pathogens. Mouthful. What are you going to do for them in the pre-hospital setting?
fluids, IV,
Maybe give them IV.
monitor.
Really, it's just emotional support and transport if they want to be transported.
Wonder why they called an ambulance and didn't go in there.
Because they're having lower abdominal pain and that hurts when they pee. And because they ain't got a car, I don't know.
It's one of the 17 cars
They don't
in
have
the
a car.
driveway. This one you go straight to the hill.
All right, dysmenorrhea, what is that? Painful menstruation. I mean, that's a given, right? Periods hurt. They don't not hurt. If they don't hurt, then something's wrong with you. They do hurt. That's true. You can have headache, faintness, dizziness, nausea. You can also have some diarrhea, back pain, leg pain. Everything can hurt. Worse. Worse 3 to 7 days. Syncope can occur. Why would syncope occur?
Pain.
From pain. How can pain make you pass out?
Your body's just like, I can't
Because
take
your body just can't take the pain. You'll have people pass out from pain. Because more often in women who are not sexually active and women who have not born children. I disagree with that because I swear after 2 kids, cycle to me has been worse than it was before children. But for some reason your book says that it's better. Or it's worse before children. I don't agree with that. Alright, middle smirch. Middle smirch. I can't say that. What does that mean?
German for middle pain.
It's German for known as middle pain. It occurs in a normal mid-cycle of a menstrual period, so it's middle pain, so it happens in between your cycle or in the middle of your cycle. Usually lasts about 24 to 36 hours. That's the most uncomfortable pain. And it's characterized by right or left lower quadrant abdominal pain, usually from a rupture of a follicle. They, of course, neither one of these, dysmenorrhea or middle smirch, do not pose a threat to your life. It's not going to kill you to have menstrual cramping in your cycle. Might make you want to die, but it's not going to kill you. Okay? They do think they're going to die. Especially for these girls who get their period for the first time. Alright, infection of the uterine lining occurs from retained placental tissue. Also can be caused by STDs or any other female anatomy infections. What is this called? Which one is it? So what's the correct answer? Endometriitis, which is inflammation of the endometrium. Okay, it can be caused from STDs, any type of infection, or any type of retained placental tissue. It is inflammation of the uterine lining. And if left untreated, it can cause sepsis, death. It can also cause you to be sterile, which means you can't produce any more eggs to make any more babies. Signs and symptoms, they complain of fever, a purulent vaginal discharge. What does that mean? It's more like a greenish yellow discharge. They can also have lower abdominal pain. What do you do for these people in the pre-hospital setting? They've got a pretty good infection, right? So they're probably going to need an IV and some fluids. Transport, especially if they're septic. If they're septic, what are they going to look like? They're going to look like crap, right? They're going to have a fever, they're going to be hypotensive, they're going to be tachycardic, they're going to look like they're going into shock, so fluids, IV, transport in position of comfort.
So, you know, with working in the hospital and everything, it always seems like the 75-year-old ladies that come into sepsis, it's always urosepsis. Is it just because they don't realize they have the UTI, or they just ignore it?
Well, you got to think, in that area, the sensation has decreased. And the older women get, they just don't think like they're supposed to. And when they wipe, they do this measure. If you watch your older ladies in the hospital, they do that measure where they just wipe from front to back several times and cause bladder infection.
Well, because I know when I did clinicals last semester, I know we had a arrest come in, and it had to be urosepsis because when they put the Foley in, it was like chunky discharge.
Oh.
To use your words. And, yeah, because her pressures are low, and it was just, they crash so fast.
Well, and once the infection goes to the bladder in these older women, what does infection do to your neurological status? Causes your ultramental status, right? So they don't realize that they've got a problem until it's too late.
And then they probably already had some kind of
Right. And their immune system doesn't work like it's supposed to.
Good.
All right, so treatment in the hospital setting, they're going to get antibiotic therapy, and they've got to remove whatever foreign body tissue could be there. This is common on women who have just had babies and go home and come back with a fever and abdominal pain and nausea and vomiting, because what does the doctor do with that placenta? Umbilical cord? He pulls on it. I hate that. Always made me so mad when they do that. You sit there and pull on it. If you're pulling that placenta, what can happen? Parts of it can be retained. Okay? And if parts of it get retained, if they don't have an automatic postpartum hemorrhage, then that placenta tissue sits there and abscesses and gets nasty in their endometrium. All right, what is endometriosis?
Endometrial tissue growing outside of the uterus.
Endometrial tissue growing outside the uterus. Now, what can this cause?
Pain, very bad
It can cause very bad abdominal pain, but one thing that it causes a lot of childbearing women who are trying to get pregnant, go and find out that they are infertile because they have endometriosis. It's kind of really sad that that happens. More common in women who defer pregnancy. Average age of a patient is 37 years. But we're seeing this more and more and more in these younger females who are trying to get pregnant. I'm not sure why. They've been doing some studies to try to figure out what causes endometriosis. They don't know if it's a genetic problem or if it's a hormonal imbalance.
How do you find out?
They do a uterine biopsy.
My God, there's so much wrong that can go with your main area of treatment.
Sad. To make you respect women just a little bit more.
Makes me be glad that I'm not a
Makes you glad you know.
When you say the first grade, you feel like around what age?
Average age usually about 37 years. So you want to have a baby before you're 35, typically. Because after 35, that's when you start having some chromosomal abnormalities in the fetus.
I was watching 1960 County, and they were saying like at 30 it's 1 in 2,000 chance of Johnson girls, and at 40 it's like 1 in 1,000, 45 it's like 1 in 500.
Mm-hmm. It's very high.
Oh, higher than that.
They can also have to have surgery. Most of these patients have to have surgery, have to have everything removed. Usually have to have a hysterectomy. And it's their baby house that's messed up. So if your baby house is messed up, you think you can house a baby? Nope. All right, what is a pregnancy that develops outside of the uterus? Tell me what a pregnancy that develops outside of the uterus is called. Pregnancy that develops outside of the uterus. Ectopic pregnancy. All right, where can that occur? Where does it happen at? Happens in the fallopian tubes. All right. Can a fetus, or what they call a zygote, a zygote's what it's called when it gets fertilized. It starts growing right here. What happens at 6-week mark? It gets a lot bigger, right? If it attaches in the fallopian tube and gets bigger and 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 grows that nice little pretty baby, what's going to happen?
Your blood is
Gonna rupture.
It's going to rupture, and what's going to happen?
You can die. You can die.
Lots of bleeding, right? You're going to have tons of bleeding. And it is a gynecological emergency. These people can die very quickly. My mom, actually, I was in high school, and she got her tubes reversed. I still don't understand to this day why she did that. Because the guy she was married to was a total loser. But she actually wound up getting pregnant, and she was at work one day and complained of a really bad abdominal pain. So they took her to Lanier, and they set her out in the lobby, and then they brought her back, and they're like, well, you really need to go see a GYN. So they sent her to East Alabama. East Alabama kept her out in the waiting room for 2 hours. So Dr. Smith came out there and got her personally and took her to the back. Her ectopic pregnancy that she had ruptured, and she almost died in the waiting room of East Alabama. All places. Ectopic pregnancy is an emergency, and these people can die very quickly. They can bleed out. Okay? They're going to have either right or left lower quadrant pain. Now, what happens if they catch an ectopic pregnancy early, but the fetus is still, the baby's still alive? There's still a heartbeat. What happens to the baby? Dies. That is sad. That is really sad. I had a friend of mine, I miscarried before I got pregnant with Annabelle. And a friend of mine miscarried at the exact same time that I did, except she had an ectopic pregnancy and had to have a D&C, but her baby was still alive when they had her the D&C, which was just horrific. So you kind of rather a rupture on its own than have to have them remove it, because that would just be.
How far along, I mean, if you're gonna have.
It's usually
viable
6 to 8
fetus-
weeks that the.
But I mean, how long can,
It can only last 6 to 8 weeks in the fallopian tube.
oh, okay.
And they can't take it and attach
So
it.
you're not gonna have like a viable.
No, it would not be viable. It's only viable after how many grams? How many grams it have to be for it to be considered viable? You wanna know? 500. The baby has to weigh 500 grams, and it's usually around 20 weeks that it can be considered viable. Yes, sir?
Don't miscarriages happen off good tip?
Yeah, they do. You're surprised exactly how many people have miscarriages.
Don't they usually happen once before you get pregnant? Like, most people have them one time before they get pregnant.
Some people can have them and not realize they've had one.
I feel like I've read that in a book somewhere. Like, before you actually get pregnant, you usually miscarry before you actually get pregnant. It's like 50% of the population does that.
I didn't know that. There's a lot of people out there that have miscarriages that you don't really know. Because when I had mine, I had a really hard time with it, because we were trying to get pregnant for a really long time. And I had a really hard time having mine. And there's like so many support groups online that you can go to and talk to people, and there are just bukus of people that have had miscarriages. And people come out of the woodworks to talk to you about when they realize you've had one. They're like, I had one at so many weeks, and this is what happened. Everybody's experience is different, but what a lot of people don't understand is when you have an ectopic pregnancy or a miscarriage, you're birthing the baby. Your hormones and stuff still do the exact same thing. The pain is nowhere near as severe as having a baby, but your body still goes through that process, and it's still pretty painful.
It's bad when you have, they make you like deliver it.
Yeah.
My sister had that.
That because I don't.
She would rather not ever have to do that.
Yeah. I have a friend of mine that's done that 3 times, and I don't know how she. Miserable. All right. We already said pregnancy develops outside the uterus, and it's usually discovered in the first 2 months, which is usually the first 6 to 8 weeks. They can complain of vaginal spotting. They're not going to have outright vaginal red bleeding. They can have some spotting, but what they're going to have is nausea and vomiting and really bad abdominal pain, either on that right side or that left side. And if it's that right side, it can also make you think of an ovarian torsion. It can make you think of what else? Appendicitis. If rupture happens, they're going to have internal hemorrhage. They can become septic. They can go into shock. And what does shock lead to? If it's not treated? Death.
So if they had an ectopic pregnancy, if they were to get a pregnancy, would show up with their pregnancy?
Hormones are still there. Once confirmed, it is treated with surgery. So pre-hospital setting, what are you going to do for these patients who you suspect have an ectopic pregnancy?
Get a line, so
Line. Usually what size?
large.
You want a large bore IV. 16 or an 18. Fluids going. Monitor their vital signs how often? Probably about every 5 minutes. Especially if they tell you I'm about 6 weeks, 8 weeks pregnant, I'm having really bad abdominal pain, I've had some spotting. That should be a trigger for you right there that, hey, they probably have an ectopic pregnancy. All right, we've been going for about an hour. Let's take 5. Go pee. I want y'all to stand up. Do something for 5 minutes. You got to get your brains working again.
Yeah.
Hopefully we're out of the gutter now.
Question for you. What peds clinical? My mom works at a daycare. Well, actually, she's in the chemo and works at a daycare.
Started.
What was that day? The
25th.
25th.
All right, vaginal bleeding. There are tons of things that can cause vaginal bleeding. Onset of labor, STDs that have caused problems in vaginal area, tears, lesions, a spontaneous abortion, also known as a what? Miscarriage. Problems with the placenta, like abruptio placenta or placenta previa, which we're going to talk about when we get to OB. All these things can cause vaginal bleeding. So you got somebody who comes in complaining or calls ambulance because they said they've got vaginal bleeding and abdominal pain. What are some questions that you're going to want to ask these patients? When was your last menstrual cycle? When did it start? How much? Like you could measure how much, like how many pads have you gone through today? How many tampons have you gone through today? What else?
I've never heard the long part of that.
Has this ever happened before? Has this ever happened before? Is this abnormal for you? What color is the bleeding? Could that make a difference? Can tell you if it's a problem that's up high. If it's old blood, what's it going to look like? Brown. Brown, rust color. What if it's brand new blood? Bright red. All right, never assume a vaginal hemorrhage is due to normal menstruation. Women can also have what they call straddle injuries, trauma to the vaginal area causing tearing or internal vaginal damage. They can cause bleeding. Can be life-threatening and can lead to hypovolemic shock and death. Now, if it's a normal menstrual cycle, can it lead to shock and death? No, a normal menstrual cycle is not going to lead to shock and death. But a lesion, a tear, postpartum hemorrhage, those things can lead to shock and death. There's something buzzing over here. Maybe a little scary. Okay. Thought I stepped on a wire or something. What is dysfunctional uterine bleeding? It's dysfunctional. It's not supposed to be happening, right? Can it happen whenever ovulation does not take place? Usually, the end result is overproduction of uterine blood flow. They can have uterine bleeding with noticed change in the menstrual cycle. They're not supposed to be bleeding right now. Ovulation didn't do what it was supposed to. Their cycle's really messed up. Maybe it's some hormonal imbalance. It's either less than 28 days or more than 35 days apart. These women this usually occurs to women who have a hormonal imbalance, who are not on birth control or going through menopause. It changes with each cycle, either they're early or they're late every time. Their bleeding can be heavier than normal. Their cramping can be worse. Soaking through a pad or a tampon every hour for 2 to 3 hours in a row. That's a lot of blood loss. Way more than that normal 25 to 60 milliliters, right? They can have tenderness or dryness in the vaginal area, bleeding that lasts for way more days than it's supposed to. Physician care, they're going to do a pregnancy test, maybe IV hormone therapy. What are you going to do in the pre-hospital setting? Comfort measures. Vital signs, if they're showing signs and symptoms of shock, which would be what? Hypotension, tachycardia. What's the respiratory rate going to be like? Increased respiratory rate. Possible altered mental status. You want to give them an IV, some fluids. Transport in position of comfort. Have you noticed a routine here with gynecological emergencies? Most of them have to have IV, fluids, but the majority of them are emotional support, transport. What is a uterine prolapse? Where your uterus starts coming out. Where your uterus comes out of the vagina. They can complain of an abnormal feeling in the vaginal area, feel like something's protruding out, and you look and you see this like a ball of flesh, as big as your fist. How do they get that back up in there? They can push it back up in there, and if medical direction tells you to, with a gloved fist and hand, you can push the uterus back up into through the cervix, up in where it's supposed to be. What can cause a uterine prolapse?
Babies. Having babies.
Having a baby can cause it what we call a uterine inversion. We'll talk about that in OB, where the baby comes out so forcefully and everything comes out, everything just shoots out fast, that the uterus also comes out through the cervix. All right, what other things can cause a uterine prolapse?
Being old.
Old age. A lot of women have uterine prolapse. Because everything's not holding tied up there like it's supposed to do, and everything just falls out.
What about that condition that some girls have, like, is it the same thing with, like, some girls like have that net come in and then,
Mesh and stuff, because their ligaments aren't holding things what they're supposed to.
you know, I mean, could they have that?
Mm-hmm.
Because, you know, she got them, like, they had all that stuff put in, some kind of mesh thing.
Because their cervix would hold a baby. Yeah, that's why. It is held in place by connective tissue, muscles, your broad and round ligaments. All these ligaments over time get stretched out. Especially your older women are more at risk for uterine prolapse because everything's stretched to the max and nothing's being held tied up. Also, having babies. you're using those ligaments and those muscles pushing babies out over time, depending on how many children you have, everything can just wind up slipping on out.
The lady, that Cougar lady, she said she was getting ready to have her 20th baby. She's planning. So will she be prone to have 20th?
I'm surprised those babies don't just fall out. I mean, she could just squat and they come out. I don't understand
You see
how.
that Jimmy Fallon where they
That
like,
she just
open
needs to
their
stop.
legs, like machine gun babies coming out.
All right, other problems, trauma during childbirth, pelvic cavity tumors, all these things can cause a uterine prolapse. Also, obesity. Why would obesity cause uterine prolapse? Extra weight. When people are obese, where they carry a lot of that weight at? Right here in this area, right? Where are those ligaments at? Right down here in this area. You got all that extra subcutaneous tissue and fat tissue on top of those ligaments is going to press down.
Well, that's what it is.
If mild and asymptomatic, treatment may not be necessary. Other patients might have to have mesh put in there to hold things up. Weight loss, smoking cessation, cough prevention. Cough prevention, what would that make? Why would that make a difference? When you cough, you have pressure in that area. Things get pressed down. So if your ligaments aren't holding things like they need to do, you cough, all of a sudden your uterus is in your underwear. Avoid heavy lifting and straining. Symptomatic wise, they're going to have problems urinating. You gotta think that uterus is prolapsing out of the vagina. Where is the urethra? On the top part of the vagina, right? If the uterus is coming out, you're going to put constricting measures on the urethra, so you're not going to be able to pee like you need to. They're also going to have, I don't even know why they would even attempt intercourse if their uterus prolapsed, but that's in here too. You would have difficult having intercourse or pain, as you can imagine. Or it might put everything back up in there like it needs to be. Also have vaginal bleeding. You would have a heaviness in the vaginal area. You got something hanging there that's not supposed to be there.
Can you not, like, putting this thing back up in there, like, tear it?
Yes, you can. It's like I'd be very gentle.
Doesn't seem like it would be, like, exactly the thing you want to put your fist up.
You will see doctors. I had one lady, she's an older lady, she came and her uterus was practically hanging out of her. And the doctor took a gloved hand and with his fist and pushed it all the way back up in there.
Seems like you want to be a little more careful.
Yeah. Most of them have to have surgery, and sometimes it can be pushed back up in there, especially like for people who have babies, that uterine, what they call uterine inversion, where everything comes out and the uterus just kind of inverts itself out through the cervix. You can use a gloved hand to push back up in there, because I think your cervix is about 10 centimeters dilated. So the uterus is going to come out fine. You can use your gloved hand to push everything back up in there like it's supposed to be. But for these older women,
I mean, that's
it's
not dilated.
Right.
So it's
Everything's just, it's not an inversion where it's coming out through the cervix. It's just the whole uterus itself is not up high like it's supposed to be. It's just all the way down. And you can push it back up there, but it's not going to stay. It's going to stay there for a little bit, but these people are going to have surgery with some kind of mesh lining helping hold everything up.
I have actually seen, working at surge, like older women who put tampons in to keep it up and forget about it. Like, literally, you wouldn't know how long it was in there.
These patients, if you see one or come up across it out in the field, if they're asymptomatic, not having a lot of pain, then you would use saline-soaked gauze, just put over it, and transport them. You don't try to invert it. Vaginal foreign body. It is not uncommon to find foreign body inserted into the vaginal area. I had one lady come in one time, she was complaining of abdominal pain, a very foul-smelling odor that her boyfriend noticed when they were having intercourse. And come to find out, we did a vaginal exam, and she had a tampon that had been there for, she did not know how long. And when the nurse practitioner, how do you know that? I don't know. How do you do that? I have no idea. But they pull it out, and it's literally this.
Please don't say
It just got disgusting. It reminded me of a wet rat.
Oh.
It smelled like it stunk up the entire ER. That was the worst fouling.
That's what I would like.
I have ever seen in my entire life. It was horrible, horrible, horrible. crazy part about this story is she had broken up with her boyfriend, and then they got back together, and he had come over several weeks or months before, and she was on her cycle, and they had sex. She had put a tampon in, and they had had sex, and he pushed the tampon up there. And so she forgot about it.
Months.
Several weeks to months before. So she didn't remember it. That's why she didn't see a stream or anything.
She didn't have a discharge
Yes.
before?
No,
Like-
after. Those are people who do not get toxic shock syndrome. Why, I don't know. Vaginal foreign body can be from a psychiatric disorder. Psychiatric patients are known to put things where they do not belong. Unusual sexual practices. I had a guy come in one time who had put a Volve candle holder up his rectum. A glass Volve candle holder.
What?
A glass, you know the little glass Volve candle holders?
Yeah,
He had put one of those up his rectum and had to have surgery. I actually busted it in the middle of surgery and he almost died.
Have you seen the show on Discovery Channel called Sex? Send Me to
Oh,
the
I
ER?
watch that all the time.
It's not called what?
Sex, Send Me to the ER.
No.
That's
Yeah.
crazy.
I'll have to watch that. I'll
Now,
have to watch that.
you know,
That sounds funny.
there's really, when I worked in recovery and stuff, for 5.5 years, once a month, we had a guy come in to get a foreign body removed from his rectum. And, I mean, I know that's not vaginal, but people that push it a little too far, it's always the wife did it while they were sleeping. And didn't do it themselves.
We had a guy one time who did a toothbrush.
You know what I'm bragging?
I just gotta get some hygiene.
My favorite
I had a guy
was came in with golf
the
ball.
whole vibrating.
Most of the time, vaginal foreign bodies, women don't get creative like men do with the candle holders and the toothbrush and the Coke bottles. And the peanut butter and jelly, you seen that one on the internet?
What? No, God.
Peanut butter and jelly, there's a peanut butter and jelly jar. They have x-rays of that on the internet somewhere. I remember seeing. But most of the time, it's either a tampon that's been pushed up in there that they've forgotten about. Broken pieces of tampons have gotten up in there whenever they rupture. Forgot or lost things that have been put in that area that cause discomfort and vaginal discharge. They're going to have an odor, a very significant odor. Lots of vaginal discharge. Of course, they're going to have pain and urinary discomfort. In the pre-hospital setting, do you remove these objects?
No.
Do you even mess with that area? No. A lot of time you really visualize the area if they have trauma or they have a baby coming out. Then you visualize to see if there's something that you need to do that can manage the life threats there. Otherwise, you leave it alone. Right? That's the good part about being an EMS is we ain't got to mess with that. All right, now into the assessment part. Finding the cause of lower abdominal pain is difficult in both men and women. There are so many different things we've gone through today and other things that we've talked about that can cause abdominal pain and vaginal bleeding. So getting to the bottom of what's going on, doing your sample history, your OPQRST, asking all the questions necessary, you know, this pain, when did it start, what type of pain is it, how long has it been going on. So many different things can cause abdominal pain. Your goal in the pre-hospital setting is to identify conditions or problems that can be treated immediately. Are there any problems with the ABCs? Rapid transport. They need any help with their ABCs, you're going to fix those. Other than that, you transport them in a position of comfort and emotional support. Y'all already know what history of present illness is, right? We don't have to go through that. Interview should also include a thorough obstetrical history. What do I mean by that? When's your last menstrual cycle? How many pregnancies have you had? How many deliveries have you had? Is there any way you can be pregnant? All those things. A female patient will always give you accurate information about her history. Is this true or false? False. It's false, right? False. She will not always be honest, especially the younger they are, the more false they are. Okay? I put true, really. We're going to talk about this. If they are complaining of an OB problem, we're going to ask them if they're having vaginal bleeding. When did it start? How much bleeding are you having? Have you noticed any tissue coming out? Also, do they use contraceptives? Do they use tampons? Or excuse me, do they use tampons, not contraceptives? Do they use condoms or do they use birth control? Do they have an IUD? What can an IUD cause? Infection, pain, sepsis, sterility. Yeah, IUDs are bad deal. Our OB would never put one in. I asked about it right after we had Annabelle. I asked about an IUD, and he's like, I'm not putting one of those in. because IUDs actually can cause the egg to get fertilized. So you make a baby, but it makes your uterus where it can't house a baby. So it's just like doing an abortion on yourself. That's why our physician wouldn't do it. And I didn't know that about IUDs either. Until you told me that, I was like, I don't want one of those things. Also, if they had any history of trauma, and what degree of emotional stress are they in? Especially these women who've been trying to conceive for so long, especially whenever they have vaginal bleeding and they're pregnant and they're having a miscarriage. This can be a very emotional time for them. So be supportive and empathetic. We're not sympathetic, right?
No.
We're empathetic. What's the difference? What do I mean by when I say I'm sympathetic towards you? How do I behave? I'm sympathetic. You know, I've been there. I know what it's like. I'm so sorry. We don't act that way, do we? We're empathetic. I'm very sorry that you're going through this time. What can I do to make you comfortable? What can I do to help you? I'm very sorry for your loss. Or whatever else you want to say. But you don't ever say, you know, I've been there. I've been in your shoes. As much as we've always said that. I mean, how many of us usually say that? You do see that a lot, especially in the hospital setting. You'll see nurses talking to them, telling them, well, I've been there. I know what that's like. I had one nurse who worked in the ER. She doesn't work there anymore. But every patient that would come in, she'd know their whole life story, and they would know hers. Why she never got any work done. They sit there and talk about all the things they had in common. Physical exam. When is the only time you look at the vagina? When you got to. If they're complaining of something coming out or falling out or a lot of bleeding, you can visualize that area. If they're having a lot of vaginal bleeding, you pad with some pads and leave it alone, right? You don't ever put anything inside. Never physically assess that area. Also losing a lot of blood, you check their ABCs. Maintain their vital signs every 5 minutes. They're critical. Palpate the abdomen for masses, tenderness. Look for any guarding. If their abdomen distended, they have any rebound tenderness. Why would they have rebound tenderness? Appendicitis is the #1 cause of rebound tenderness, right? They'll have that right lower quadrant pain. You can press in, and as soon as you let go, it's when they start screaming bloody murder because it hurts so bad. Management for most of these gynecological emergencies is support of their vital functions, their ABCs. Giving some emotional support. Some might need oxygen. Some might need IV and fluids. Position them in comfort. Left lateral recumbent position or need a chest position. Why do you always put people on their left lateral side? I learned this the other night in ENT.
It's supposed to be better to let blood through the body. Especially like
Okay. Lung-wise, Miss Curry taught me this. Lung-wise, how many lobes do you have on the left side? How many lobes do you got on the right side? 3. So if you lay them on their left side, they get better airway control. Push them. She did make that up? I thought it was pretty interesting. I was like, oh, I never knew that. I was wondering why you put people on their left lateral side. I was like, okay, whatever. Also on their left side to keep air embolism from going to the lungs. All right. Also control any vaginal bleeding with application of pads or sterile dressings. Thing's not working anymore. During transport, monitor them, assess their ABCs, reassess their vital signs. What do you do during sexual assault?
Put everything in a bag.
During sexual assault.
All right, if you are called to someone who's complaining of a rape and that they've just been sexually assaulted, once police are on the scene, they secure the scene, it's safe, and you get to go in, what are you going to do with this patient?
Do not bully.
Preserve everything. You want to tell them, make sure that they don't use the bathroom. No peeing, no pooping. You want to get as much information from them as you can. Be empathetic towards them. This is a very emotional time. Only get information that's necessary. You don't need to ask 500 questions about the rape itself. You need to ask, what's wrong with you? Where are you hurting? What can I do to help you? All right, you don't need to say, well, how did he come in? Well, what did he do to you? You know, that stuff's really not necessary for you to ask. It's necessary for you to figure out what's wrong with her. Are there any life threats that you can fix? Preserve any evidence that might be there. Other than that, just transport them. It says 1 in 6 women have been sexually assaulted or will be sexually assaulted. How many women are in here?
Are you really about to do that?
14. There's 14 women in here.
Two of y'all.
So that means at least 2 of us in this room who've either been sexually assaulted or will be sexually assaulted. That's a really bad statistic, isn't it? All right, first priority is to manage any injuries that pose a life threat. So if there's an airway problem or circulation problem, you want to fix that. If possible, interview and examination should be done by the same sex. Now, sexual assault could be a female or a male, right? Most of the time it's female, but it has been a possibility to be a male patient. Victims should not be questioned in detail about the incident in the pre-hospital setting. Just gather what information you need necessary to treat the patient. Allow them to speak openly. They might be very angry. They might be in denial. They might be extremely fearful. I've seen all 3 of these patients. I've had rape victims who have been mad where they tear up my room and throw everything that they could on the floor, throw everything against the wall, get so mad and frustrated because they just want to hurt somebody as much as they've been hurt. I've also seen the ones who deny. They're like, oh, maybe it didn't happen. Maybe, this didn't happen to me. Everything's fine. Nothing's happened to me. And I've seen the ones who were fearful that hide in the corner of their room in the fetal position. They're all very difficult to treat and assess and figure out what's going on. So you can imagine how this could be a very traumatic event for them. And you want to be empathetic as much as possible. Physical exam. Look at any trauma that the patient might have. Try to pad any vaginal tearing or bleeding that you see. You don't want to mess with it as much as possible. Try to just pad it and keep it under control. Only examine it if it's severe enough to cause circulation issues. Document every finding that you have. You need to document everything from what you see on scene to what your patient says in quotations to what you find in your physical exam. Be very professional. There are those times where you hear people say, well, she deserved it because she just went out looking like that and got drunk and she deserved it. We don't ever say stuff like that. Nobody ever deserves to have that happen to them. And you see that a lot with these chauvinistic men. Well, she comes in here in a miniskirt and a tube top, she deserves whatever she gets. How many times have you heard that? That's not true. These women do not deserve to be treated that way. Nobody deserves to have this happen to them. After you manage any life threats, give them some emotional support, transport them to the hospital. And most of the time, you'll just go in and treat any life threats they've got, and they'll probably sign a refusal and want to be taken to the hospital by the police. They don't want to have contact with many people. Special considerations, handle clothing as little as possible. Do not allow the patient to drink or to use the bathroom. Because when they come into the hospital setting and we have to do those rape kits, we have to just literally stand them on a piece of paper, take every article of clothing off one at a time, go over them with a black light, looking for any secretions that they might have. We have to swab everything. We have to cut all of their hair in different places. We have to clean under their fingernails. A rape kit can last for 2 to 3 hours. Those things take forever to do. But you don't want them doing anything. We have to do vaginal swabs, they have to do anal swabs, oral swabs. They have to do everything. And then give them medication for STD prevention, things like that. Any questions? Are my babies pretty? They do, don't they? They're a cute little bundle of mess. Figure after all that lecture, y'all need something for you to look at.
Yes.
All right, let's go into, I'll pause this for a second. All right, we're going to start talking about OB. A lot of the stuff we just talked about in GYN kind of overflows into OB, so this kind of help it go through a little bit faster. Female reproductive anatomy, we ain't got to go through that again. I'm just going to flip on through. Menstrual cycle is a monthly event that begins with the shedding of the uterine lining and ends with pregnancy or another menstrual cycle. Is this true or false? It is true. Y'all already know that. We just talked about that. All right, here's the cross section of the female reproductive system. We don't need to go through these again, right? All right, fertilization takes place in the fallopian tube, and the fertilized egg is called what? What is the fertilized egg called? Fertilization takes place in the fallopian tube, and it's called what? The faster y'all click, the faster I can click. It is called a zygote. What's a sperm? Sperm is a sperm is a sperm is a sperm, right? So it comes out of you guys to go into the female to get fertilize. What's an ovum? The egg. And when these two meet to make a baby, what's it called?
Zygote.
Zygote. Look at y'all, so smart. All right, normal events of pregnancy. You guys can read through this. I'm not really going to go into it with how implantation works. We already talked about this. The egg goes down into fallopian tubes, travels through for about 7 to 10 days, turning into a blastocyst and a whatever other kind of cell you want to call it, until it turns into a nice little pretty baby that attaches into the uterine lining. All right? What is forming at this time is the placenta, right? The placenta takes a little while to form. So what is giving the baby its nutrients while the placenta forms? Corpus luteum. There you go. Implantation usually begins within 7 days after fertilization. So that egg goes from the ovary down the fallopian tube. It takes about 7 days, and then it attaches into the uterus. You know, if you don't like my teaching, there's a door there. You can go next door and do CPR on the table. Shut your mouth. Placenta, amniotic sac, umbilical cord. What's the placenta for? Gives nutrients to the baby. Okay. What's the amniotic sac for? Protection. Houses the baby, and that's that nice little amniotic fluid. What's the umbilical cord for? It is the lifeline. Okay. It is the lifeline that attaches to the placenta. The placenta gets nutrients from us. Then that is transported through the umbilical cord into the baby. Okay? I don't care what kind of cells and cyst it is. It's in here for you to read, but honestly, I don't think that you need to know that. Do y'all? Okay. I'm good with not knowing that. This picture actually is a lot better than mine that I drew. But you can see the ovulation takes place, egg comes out, and in this 7 days, starts to grow and change until it turns into a blastocyst, then it implants into the uterine wall. Now, for it to implant into the uterine wall, what does the uterine wall have to do? Thicken. It has to get thick. Okay? Really nice and thick to hold that baby. And you can see the corpus luteum goes until it disappears, and then you get another developing follicle. Start all over again. If you don't fertilize the baby. Now, if you do fertilize the baby, do you produce any more eggs at that time? No. I mean, that would just be crazy. Otherwise, you'd have like 10 babies growing in your uterus at one time. That's what happens. That is whenever 2 eggs come out. That's a good question. Twins happen whenever 2 eggs come out of here. Instead of 1 coming out, 2 comes out. And you can take those drugs the doctors give you to make more than 1 egg come out at a time. That's how you get them quintuplets or whatever.
That's how you get a TV show.
I did all of that one time.
No, they're still ovulating. It's just not sloughing out like it's supposed to. And that's just a hormonal imbalance where actually can cause them to stop ovulating. But that's, you don't want to do that. That's dangerous. That's the people who take the first 3 weeks of their birth control and then start their birth control new pack and start taking that week off.
Well, see, I did that.
Yeah, you don't want to do that. Don't mess up your hormone
But
production.
now I have. That's
Wait, what you just say about
Do what?
That's bad for you?
For people who have to take birth control, you know, there's 4 weeks in that birth control pack. Some people skip that 4th week and automatically start a birth control. So they don't have a period. And it messes up their hormone production. It's a bad idea. Don't do that.
So that's put now.
Yeah. You want to have a cycle. You should have a cycle. It is a normal way of life to have a cycle.
Like, what would that be? Like, what does that affect?
Over hormone production can cause you to have too many hormones that come into play, so you can have problems getting pregnant or going through menstruation or menopause early or later. Overproduction of progesterone and estrogen. It doesn't make you more feminine. It just can cause other problems. A lot of it's mood swings, water retention.
And if you don't have one, a period, then it's bad. But why is it?
You're not sloughing all that stuff off. That stuff's just staying in there. Your body, that's its natural way of cleaning itself out.
So for me,
That's why you want to have one.
why would I not? Why would it stop it? I guess. I'm just curious.
Why would the birth control stop it? Because you have too many hormones in your body. You're overproducing hormones, which makes the ovaries not work like they're supposed to, which actually cuts out your normal hormone production. But you don't want to do that. Not at your age. You want to be able to have babies.
Not right now, I don't.
Well, not right now, but that's when you take it like you're supposed to. Abstinence is the only way to prevent. All right, placenta. What's the placenta? We talked about that. It's pretty cool that women are the only population, females are the only people that can make an extra organ that goes away after birth. We can make organs. Pretty cool, isn't it?
The dolphin.
We can make an organ. Females.
Granny, why do you think that the placenta is called, when you're making a baby, you're making a person with a...
You are. Shut up, Hayden. The baby is the awesome part, but it is pretty cool though that you can make your own organ and then it goes away. Alright. It is responsible for 5 functions. It helps with respiratory gas exchange. Where does gas exchange happen in the body? In the lungs. At what level? Where at in the lungs? At the alveoli. Gas exchange for the baby happens at the placenta. Alright. Also transport nutrients from the mother. That placental barrier right there gets the nutrients from the mother and takes it down the umbilical cord into the baby. Also helps to rid the baby of waste, transfer of heat, hormone production, and it forms a barrier. You always hear that placental barrier. There's a lot of medications that can cross that placental barrier, which is why females cannot take certain medications when they're pregnant. One of the main ones they can't take is ibuprofen or any other non-steroidal anti-inflammatory drugs. Why is that? What can it do to the baby? Can cause excess bleeding, but what can it do to the baby's heart? Anybody know? Do you know what that atrial septal defect is? The hole in the heart that most babies are born with. It closes in the first few days of life.
Yeah.
Motrin will keep ibuprofen, other non-steroidal anti-inflammatory drugs will keep that open, which causes a wish-washing of oxygenated and deoxygenated blood. It's a bad idea, so you don't do it. No non-steroidal anti-inflammatory drugs. That's why babies can't take it until they're 6 months of age, because the atrial septal defect can take up to 6 months to close. Yeah.
Now, if, like, someone is pregnant and they are taking Phenergan rather than Zofran, what can that cause?
A lot of people usually took Phenergan. Zofran's a relatively new drug. For
So it doesn't
anti-medical.
cause anything?
No. I think it's still category B. Zofran's a category B or C. Both of them are category B or C's. Phenergan's a C now. And Zofran a B, I think. That's another thing too. I'm not going back over the pregnancy categories. Y'all need to refresh your mind. What's category X? Bad. Category X is anti-inflammatories. Like Toradol is a medicine that you can give in the ER. It's category X. You cannot give that to a female patient at all. What about A's? A's are safe. Most of your life-saving drugs, atropine, epinephrine, those are A's when it comes to pregnant people. All right. What secretes hormones until the placenta is completely developed? Everybody should get this one right. I know. Might be doing that for a reason. What do you think? I'm going to hit somebody if somebody gets it wrong. Seriously? And you wonder why I'm beating a dead horse? Because y'all are acting crazy? 14% of y'all didn't have knocked upside the head. I'm not even going to go over that again because we just went over it like 10 times. All right, what happens to diffusion of gases if the mother becomes hypoxic? If she's hypoxic, where does gas exchange for the baby occur? At the placenta. All right, if the mother becomes hypoxic, what happens to the baby? Baby can become hypoxic too, right? Because the mother's got to get back to normal. She's got to get her oxygen level increased before the baby can become oxygenated, before the baby gets oxygenated. Does that make sense? The mother's body has to compensate for her before it can start compensating for the baby. All right, just a little bit on fetal circulation. Umbilical cord connects the umbilicus with the placenta. Blood flows from the placenta through the 2 umbilical arteries in the cord. Oxygenated return to the fetus through the umbilical vein. Deoxygenated blood is taken out by the artery. Does that make sense? Artery takes deoxygenated blood out. Veins bring it in. You're good? You know how you can remember that? Artery away. AAA. Arteries take the deoxygenated blood away from the baby and the veins bring the good blood in. Amniotic sac and fluid. This is what completely surrounds the baby. Keeps him protected. What's in that fluid? Pee. The baby does pee. They actually drink their pee in utero. Isn't that kind of weird?
Wait, they do what?
They drink their pee in utero. Yeah, they do.
What's that?
They take that fluid in and it just goes straight through.
What's that wax?
That's called Vernex.
I have never seen, there was
Those
this
like
kid
fried
that
chicken
came out
bake.
looked like he soaked him in a candle. I mean, it
Yeah.
was, I've never seen anything like it.
Fetal growth and development. The developing ovum is called an embryo until the first 8 weeks of life. Then afterwards, it's called a fetus. What's it called when it's born? A neonate. A neonate is the first, how many days of life? First 28 days of life, they are considered a neonate. After that, they are considered a infant. In advance? All right, average pregnancy is 48 weeks and is divided into 3 trimesters.
40 weeks.
40 weeks.
You said 48.
Oh, I meant 40 weeks. I'm sorry, I didn't mean to say 48. 40. I'm glad you're paying attention. Thank you. 40 weeks. And it's divided into trimesters, so 3 separate. Calculate delivery date, referred to as estimated date of confinement. That means there's no more alcohol, cigarette smoking, partying for all these girls. It's the date of confinement. I think it is prison time. For some females, it feels like prison time, I think. They have to give up their partying. You take your last menstrual cycle. So if their first day, their last menstrual cycle, what's today? May 22nd? Let's say they started their cycle today. Alright? So 5/22. You will have to do this on the test, by the way. Alright, you add a year to it. So I'm adding a year, so what does that make it? 5/22. Alright, I'm subtracting 3 months. What's 3 months before May? May,
22.
April, March, right? March. That's 2, so it'll be February.
5 minus 3.
5 minus 3 is 2. And there you go. February 22nd, and then you subtract 7 days. What's 22 minus 7? Yeah, that's what I meant. That's right. When you're standing right here, look at it. When you're standing right here, I'm telling you, it looks like a minus. I'm sorry. It's add 7 days. So what's 22 plus 7? February 29th. So if it's a leap year, you're pretty excited. But if it's not a leap year, what is it? March 1st. I did not even mean to do that. That's pretty cool that it worked out that way, huh? Pretty neat.
Like it's the day that you first start or the day that you end?
The day that you first start. It is the first day of your last menstrual cycle. Are you ready? Let's do one. Calculated due date of the last menstrual cycle, November 7th. Last menstrual cycle, November the 7th.
Wow, how could it be the 2 answers? You add 7.
All right, y'all, come on. You don't know, just guess now.
Can you not drink it all when you're pregnant?
Can you not what?
Can you not drink it all when you're pregnant?
No.
They say like.
They say you have a glass of wine a day. Dr. McFarland used to tell me that I could have a margarita a day, which was a joke. But no, you don't want to do that anyway.
Red wine was like.
No. It's a horrible idea. If you're a good mama and you have to drink when you're pregnant, something's seriously wrong with you.
No, I've heard it. Like,
Yeah, no, you don't do that. It's bad. Bad mojo. All right, the correct answer is B. They didn't show it like it's supposed to. Oh, yeah, it's right here in between this. The correct answer is B, August the 14th. And my daughter actually was born on August the 15th, because this was mine whenever I did it last time. I was actually pregnant the last time I did this lecture. Make it easier for us to calculate. You can have caffeine. You can have up to 3 caffeinated drinks a day. Not energy drinks, like coffee or something. This is a picture of a fetus at 35 days. You can see their heart. Let me turn the light off.
Oh, it's so cute.
It's like a little alien. It reminds me of a little tadpole. See a little sample? No. You can see the eyes, the heart. The heart starts beating at what day? Day 21st. 21 days. That's when the heart starts beating.
So 7 weeks?
No. 3. 3 weeks.
Goodness.
And you don't ever know you're pregnant until the 4th week. That's whenever that's whenever your pregnancy test will show that you're pregnant. Okay, this is a fetus at 49 days. Looks a little bit more like a baby. Kind of like an alien.
How do they get pictures?
Isn't that cute? Little bitty alien. That is the end of the first trimester. First trimester, how many weeks? 12 weeks. So that's what a fetus looks like at 12 weeks.
You can't tell the sex then?
They can, but it's not good to do that at 12 weeks. It's usually 16 to 20 weeks that they check sex.
That's a boy for sure.
They can tell at 12 weeks, but you don't want to tell a sex at 12 weeks because it's probably not right.
And is it 12 weeks that you're a little bit farther out of the...
At the end of your first trimester, you're at your risk of miscarriages decreases dramatically. So that's usually when people start telling that they're pregnant. This is a baby at 4 months. 4 months is how many weeks? 16 weeks. That's usually when they start telling the sex of the baby. Now I think they're trying to do 18 to 20 weeks is when they're doing it now. I found out what Logan was at 16 weeks. Annabelle, she was 20 weeks before I found out what she was. All right, pregnancy terminology, you already know this. What does G stand for? Gravida. What does that mean? How many times have you been pregnant? All right. Para is what? How many times you've given birth, right? Dr. Sand tell y'all it's how many times you fill the oven and how many times you empty it? Is that y'all's class? He told that too? No. He'll come and tell you that. Read your picture of an oven.
This is the first day of this
And you
class.
make the cookies.
He hasn't been in here to talk to us.
That's true.
Right about that, Randy.
Mine's the measures we're going to run together. All right. T stands for term or number of deliveries. Preterm is how many preterm deliveries that you've had. Abortions count for induced abortions, medically induced abortions, or spontaneous abortions.
I just hate that one.
I hate that
I'd
word
rather it
too.
just be miscarried.
I don't even say miscarry. And they're like, you spontaneously aborted your baby. Like, no, I didn't.
No, I did not.
Abort.
It's not my choice. I did not do that. Women who have had 2 or more deliveries is known as multipara. A woman who has never delivered a child is nullipara. All right, here is a formula thing for you guys to work out with gravidipara and abortion. 24-year-old female with 2 living children, has had 2 miscarriages, and is 8 months pregnant. Has a GPA of what? 3.5, right? That was the fakest laugh I have ever heard come out of your mouth.
Well, she's 24 and she's already had 2 kids. She probably didn't go to college.
Wait, so this,
I had my first one at 24.
So probably.
no, wait.
Yeah.
no, she's
They've had 2 kids already though.
All right, so she's got 2 living children. She's miscarried twice, and she's pregnant. 8 months pregnant.
But that would mean she's had 4.
She's had 5 pregnancies.
Yeah. And then
2 living babies, 2 miscarriages, and she's pregnant now, right? Para means that she's delivered how many times?
2.
She's delivered twice. So she's had 2 living babies.
So miscarriage.
Miscarriages count for A. They count the abortion, which is why G is 5, P is 2, and A is 2.
So abortions and miscarriages do not count as deliveries?
Correct.
Here is a live delivery.
Para are live deliveries.
And it's still,
And she's still pregnant, so that baby hasn't come out yet, so that doesn't count.
so does stillborn go underneath there though?
No, stillborn goes under abortion.
Even if it's a full term?
Yep. So they're not living. All right, maternal changes during pregnancy. What happens to the female when she's pregnant? Boobs do get bigger. What else? That's the first thing you said.
Hey, I'm just saying.
Mood swing.
Mood swings,
That's
hormonal
cravings.
imbalances, cravings.
Salt craving.
Cravings can be kind of weird. I never did any of those crazy cravings. With Logan, I craved Arby's all the time. And with Annabelle, it was fruit and salad. And candy.
I mean,
I like
fruit and salad, I guess that's a good craving.
She went to sleep a lot.
Huh? I'm not making that up. I had to have Arby's on a daily basis when I was pregnant with Logan.
Really?
So I gained like
For
45
what?
pounds with Logan. I only gained 20 with Annabelle because I ate fruit and salad with her and Skittles and chocolate. I literally had to, my husband would get me a piece of chocolate every day. I'd have a piece of chocolate every day. Those little miniature things, that's not bad for you. Those little Hershey miniatures. All right, what happens in the genital area? What happens to the labia? What do they look like? Do I know? They swell, get very vascular. They turn a bluish purpley color.
Like throughout?
Mm-hmm.
Your body temperature goes up.
Body temperature does go up. All right, what happens to the breast? They get bigger, ready to produce milk. GI system, what happens there? Slows down so you get constipated, which just makes you more cranky, right? You get constipated. Because nothing's in there working like it's supposed to. And then you're also taking prenatal vitamins, which make you constipated anyway. All right, what else happens in the GI system? You can.
You pee a lot. Puts pressure on your bladder.
You can pee a lot. You do wind up peeing an awful lot. Some women it lasts the entire pregnancy, others it's the first and the last trimester. What about nausea and
Morning
vomiting?
sickness?
Hyperemesis, puking your guts up on a constant daily basis. Man, I took Zofran like it was candy with both mine. I vomited the entire time. I wasn't one of those lucky ones that only vomited a couple of times. It was every day. Every day. All right, what about the cardiovascular system?
It works harder.
Increased blood supply.
Your heart rate.
Heart rate does increase because your heart's pumping for two.
And then you also have hypertension issues because of the way the baby is able and stuff like that.
That's true. We're going to talk about that here in just a minute too. All right, what about their blood pressure?
They skyrocket.
No, it's not supposed to. It's supposed to go down. Their blood pressure actually goes down. And it stays more normal than it would if they've got other blood pressure issues. Yes.
Yeah, their blood pressure's like 128 or they're 60 something. Why would their doctor put them on a blood pressure pill?
128 over 60 something is right at that normal. The 128 systolic is a little bit above normal, so they could be considered pre-hypertensive. Then maybe they would put them on something.
If they have real bad water retention.
Yeah, also that if they got water retention to help get the fluid off. All right, respiratory system. Their tidal volume increases. What's tidal volume?
You feel like you get breathe, you go through all
They take in more air. So tidal volume is the air you're taking in. They're taking in more air. What about the diaphragm? What's happening to the diaphragm? It's getting pushed up as the baby grows. Everything's getting pushed up. So what's happened to the lungs? They're not able to get that full, deep, expanding breath, are they? All right, metabolism. What happens to that? It does increase. How much do they eat?
All of it.
A lot. A lot. A lot. All right, I'm going to make this. Oh, the cervix. We talked about the cervix earlier. What does it do? It's the gateway to the baby house, right? It's the gateway to the baby house. It's got to thin and dilate for the baby to be able to come out. Okay. One thing that you will see, you won't see as a paramedic, but your OBGYN will see when they do your vaginal exam, is they will see a softening bluish discoloration of the cervix. It's normally that pink color, but when you're pregnant, it will turn a bluish purple color, and that's just called a Chadwick sign. Cool. FYI for you.
What chapter shows when it turns out?
When it turns blue. When you're pregnant, the cervix turns blue. It's a little bit more vascular and turns blue. It's like your vagina turns blue. Blue, purple. When you're pregnant, the vaginal area of the labia get more vascular and they turn bluish purple. So you can imagine if that area is a lot more vascular, if they have a straddle type injury, they can be at risk for a pretty nice little bleed down there. All right, bladder, we talked about urinary frequency a while ago. They are going to pee a lot more. They're going to have a lot of pressure on their bladder, usually at the first trimester and the third trimester. Breast, we already talked about that. I talked about GI system. I can go through all this. A pregnant female involved in the MBC is unconscious. Due to her GI changes, what is she at risk for? Pregnant females in an MBC is unconscious. Due to her GI changes, what can she be at risk for? She's unconscious. She's in an MBC. Think about all the different GI changes that she can go through. What is she most at risk for? That could be problematic. Problematic rise, Due to her GI changes, she's at risk for aspiration. Definitely would not be placenta free, but we'll talk about that in a few minutes. Ruptured uterus is a possibility depending on what kind of MBC she was in, but since we're talking about GI problems and she's unconscious, she's not able to control her airway, she is at risk for aspiration. All right, cardiovascular system circulation. Sorry, I kind of went through all this a while ago without having to read through the slides. She will have an increase in tidal volume. We talked about that. Metabolism. They will experience a weight gain of about 15 to 30 pounds. That's about norm. Glucose. What happens to the glucose? For most pregnant women, it's fine. You don't have any problems with glucose. But for others, their glucose is depleted, and they can wind up with gestational diabetes. They're not producing enough glucose, or they're not utilizing the glucose that it needs to be utilized. The cells aren't taking it in like they're supposed to. Their blood sugars are either getting high or too low. They have to be on medication for gestational diabetes. Someone who has gestational diabetes is at risk later in life of developing type 2 diabetes. Their pancreas isn't working like it's supposed to. They're not getting enough, they're not storing the glucose or utilizing the glucose that they need to.
Why is it so bad to be pregnant with type 2? I mean, I know as far as the baby's taking up glucose and all that, but...
Your babies actually get a lot larger. Why they get a lot bigger, I'm not exactly sure why they do that. But you're at risk for having a larger baby. Your baby's also at risk for developing diabetes, juvenile diabetes. It also causes cardiovascular problems and respiratory problems in the mother
They
as
just
well.
like watch these people really close.
Yeah.
At what weeks do you do that?
28. 26, 28 weeks. You drink this sun-kissed flavored junk.
Why does it wait till that time?
Because everything's pretty much developed by then, so that they can tell if your body's rejecting.
You don't hear it. It's like
Yeah.
like you never heard of that.
Yeah. Cultural considerations. Different cultures believe different things. The Muslims are very strict in female covering up, and they are not allowed to be questioned or talked to by male healthcare professionals. They have to have a female.
Mormons want a water birth.
They want a water birth? Really? I didn't know that. I didn't do a water birth. That just sounds crazy. Adolescent pregnancy. This can be complicated because a lot of your adolescent pregnant females don't get the prenatal care that they need because they're hiding it. So they don't get the prenatal care. So they're not taking prenatal vitamins. They're not getting regular testing. They haven't had an ultrasound. They usually don't have a clue how far along they are. They don't know if there's only one baby or two. Scene size up for OB patients. Take your standard precautions, BSI. Consider calling for specialized resources if you need to. Determine if there's a problem. What's the nature of illness? Is there a mechanism of injury? Not all pregnant females are calling for help because they're in labor. They could be calling because they hurt their ankle, they tripped, or they were in an MVC. Just because they're pregnant, don't assume that they're in labor. Form a journal of impression of your patient. Y'all know how to do primary assessment. Do we need to go through that?
No.
All right, checking their ABCs. Airway, breathing, circulation. Y'all know that? You report to an MVC with a female who is 34 weeks pregnant. Patient is hypotensive and tachycardic. What position do you transport her in on a backboard? If you have to lay her on a backboard to transport her into the hospital, what position do you put her in? I like to see you put a pregnant when I'm prone. It'll happen. Somebody actually picked prone. Somebody just being stupid today. It's the same person that picked whatever it was earlier. I don't remember. The correct answer is left lateral recumbent position. How are you going to do that if they're on a backboard? Elevate the backboard itself. Put pillows or blankets or something under it to turn on the left side. Transport decision. If imminent, prepare to deliver on the scene. If it is an OB call, they're calling you because they are in labor. If the head is crowning, you're not going to put them in the back of the ambulance and transport, right? You might want to, but you're not going to. You're going to have to prepare for delivery. Provide rapid transport for patients who are having significant bleeding and pain. If you do not see the baby is crowning, then you can go on to the hospital. If they are hypertensive or having a seizure, or if they're having an ultra mental status, you need to transport these patients as quick as possible. Gather as much information from them or their family members as you can. You need an obstetrical history, which means last menstrual cycle, so you can kind of calculate a due date and figure out how many weeks they are. And most of your pregnant patients are going to tell you, hey, I'm so many weeks along. I'm due, blah, blah, blah. How many babies are in there? It's a good question to ask. You know, is there one or two? If I'm getting ready to deliver a baby, I need to know if I got to have stuff for one baby or two, or 3 or 4, or how many they got in there.
4.
You also need to know when the contractions start, how long they've been going on, have they had a bloody show? What does that mean? Have they lost their mucus plug? What's a mucus plug? You know that cervix we said has to thin and dilate? Well, when it opens, there's a plug of mucus that looks like bloody snot. Exactly what it looks like. It's stuck up in the cervix, and once the cervix starts to thin and dilate, that mucus plug will come out. Usually delivery is in within 48 hours. No. You'll know when you water break. You'll know when it's mucus plug. It looks like snot.
So, which is first?
The mucus plug comes out, and then the water will break. You can't have a baby born without the water breaking. I had a student send me a picture one time. I don't know if I saved it or where I put it. I wish I could have found it for this lecture. He sent me a picture of, and this happened in Columbus with Care Ambulance. They delivered a baby that's completely in the amniotic sac. The amniotic sac and everything came out.
I've seen that, yeah.
And you can just sit there, the baby's just moving his little arms. And I was like, in shock when he put it. I was like, wow, that's really neat. And they said the medics didn't have a clue what to do with it. You pop it, you bust the sac. You tear it. You tear the sac, and then you suction the baby. Suction first, of course. You got to suction their mouth and their nose. Get all that stuff out, and then that's when you dry them off.
So they didn't know what to do, so they just took the phones out and started taking pictures?
Yep. They're delivered in the back of the ambulance, and they brought the patient in like that, still in the amniotic sac. Luckily, the placenta was still in the mom, and the baby was still attached. Otherwise, the baby would have drowned.
Okay.
All right, y'all. So you know if they've got any infectious disease?
Say, what do I do?
Huh?
They didn't call me.
I don't know. This came from a crazy student too, so I don't know if he was really full of it or.
That'd be the first thing I do.
Also need to know if they have any pregnancy-related issues such as gestational diabetes or preeclampsia, which we're going to talk about that here in just a few minutes. Where is their pain? How bad is it? When did it start? How long has it been going on? We already talked about a bloody show. Are they allergic to anything? Have they taken any medications in the last while? If they took narcotics within the last 4 hours, how might the baby come out? Probably with a low APGAR score. They're going to be drugged. They're going to not have any grimace whatsoever. They're probably going to have a low respiratory drive. They're either going to have to be intubated or stimulated and oxygenated.
Have you seen that show where they get like dependent on these, like those babies get, they're pregnant, they get dependent, and they have to wing them off?
Yeah, isn't that awful?
That's bad. So,
Those women need to be shot and sterilized.
Wouldn't they, I mean, if they're shot, it's not for the babies to be made.
That's true.
I was watching like the
Sterilized.
Wild
We can't
Wonderful
shoot
Whites or
people.
whatever.
They need to
Well,
be
you said they
sterilized.
need to be shot.
They do need to be shot.
You can shoot them. You may as well shoot them. Don't spend the money to sterilize them.
I mean, 22 cents for a bullet, right?
Yeah, I wish.
All right, assess general appearance and skin color. How do they look? Are they pink and pale? Are they puffy and swollen? Vital signs monitored often. They could get a set of orthostatic vital signs. What do you use orthostatic vital signs for?
Pregnant women.
What is orthostatic blood pressure?
You
Or
get a
orthostatic vital
standing,
signs, what is
sitting.
that?
It's when you like try and
Lying, sitting, and standing. Those are done to see if they have any
they
shift in fluid or any imbalance in their blood pressure and heart rate. It's usually an imbalance of blood pressure and heart rate of about 10 beats per minute increase or decrease, and a blood pressure usually decrease of about 10 millimeters of mercury at a time. This is significant because if they do have a drop in blood pressure and an increase in heart rate, they're at risk for syncope whenever they stand up. And you don't want a 9-month pregnant woman being at risk for syncope and then her coming from a lying position to a standing position. All that blood's going to rush down. What's going to happen to her? She's going to fall.
Brandy, well, babies' vital signs always match the mother. Like if they were in a car wreck, and like the mother's vital signs were normal, SBO was normal. I'm gonna say this is where we go. I'm putting them on oxygen and going, or would the vital signs match her?
If she's pregnant,
Yeah, like say she's pregnant.
if she's pregnant and her vital signs are normal, then the baby should be fine. But if she's showing signs of shock, then the baby's not getting good perfuse. So she's going to need oxygen and fluids and rapid transport. So most of your pregnant female, if they are in MVC, they're going to be scared. So they're going to be tachycardic anyway. Their respiratory rate's going to increase, so they're not going to be getting the good gas exchange. So you need to put them on oxygen anyway. That helps slow that down. Does that answer your question? Okay. Assess the abdomen. Make sure that you look for any scars. You know, if they've had a recent C-section with their last baby, are they doing what they call a VBAC now? Are they doing a vaginal birth after C-section? Those can be kind of dangerous because what can happen to the uterus? Uterine rupture. It can tear, right? Because they have a C-section, their stomach's cut open, but what else is cut open? The uterus, and that's when the baby comes out, right? If they're doing what we call a VBAC, which is a vaginal delivery after C-section, that uterus can rupture. It's already scarred. So they've had a C-section, just talk to them and say, you know, are you planning on having a VBAC? Are you planning on having a vaginal delivery? Or were you scheduled for a C-section? You need to get them to the hospital as quick as possible. You can measure or look at their abdomen and measure, depending on how many weeks they are. If they have the top of their fundus at their belly button, then they are about 20 weeks along. If it's up under their diaphragm or up under their sternal notch, then they are about 38, 40 weeks along. Usually at the umbilicus, or at the belly button area, the top of their fundus is about 20 weeks. And then it goes up to about 38 weeks, or 36 weeks, all the way to the sternal area, and then it goes down just a little bit to be 40 weeks. And why does it go down? Baby drops. Everything drops down to the pelvic cavity and prepares for delivery. What is this? Old-fashioned Doppler. You think you're going to use this on ambulance? Nope.
Wish we had.
Yeah.
It would be nice for you to be able to do that on the ambulance so that you can monitor fetal heart rate and see if it's normal. What is a normal fetal heart rate? It's usually about 140 to 160. If it's anything under 140 for a significant period of time or over 160 for a significant period of time, which is usually 5 minutes or so, the baby is in fetal distress. It'd be nice if you could do that out in the field. They do it in the hospital. Excuse me, it's 120 to 160. Normal baby's heart rate's 140 to 150.
What keeps you from not doing it?
Not doing what?
Just buy one.
I don't know.
I
I think it's a service preference.
probably somewhere in Texas they're doing that.
All right, if they are in active labor and you're going to have to prepare for delivery, what are some things that you're going to have? What's in your OB kit?
Sterile gloves, gown,
Okay, some
mask.
sterile gloves, gown, mask,
A Bible.
goggles,
Baby warmer section.
black blankets, suction, like a bulb syringe, clamps, scalpel. Why don't they give you scissors? Why don't they give you a scalpel? I think that's the stupidest thing in the world. Because
Is it a
trying to
scalpel?
cut an umbilical cord with a scalpel is ridiculous. Yes, you cut it with a scalpel.
Just pull it from shears.
Yeah, no,
Ooh.
you can't do that. The mother, how are you going to position her? What is birthing position?
Just like this.
Well, lithotomy position, right? You want to kind of have her tilted up a little bit, propped on something, her legs propped up. She needs at least to have 1 or 2 support people there with her. I mean, to make sure that her underwear is off. You can't deliver a baby through underwear. Would be. Give her some oxygen because she's going to use a lot of her oxygen.
Tell the
She's
husband
going
to
to
go
use all
boil
of her
some water.
reservoir. She's got to have some extra oxygen to kind of help keep her oxygenated.
You go boil me some water.
She's going to need IV, fluids going. Unless the head's coming out, then you ain't got time for all that. You got time to catch. That's about it. All right? Resuscitating the mother is the key to survival for the mother and the fetus. If you come up on a scene where somebody's had a very traumatic event, they've had a gunshot wound to the head or to the chest, or if they've got MVC, head-on collision, anything that the mother has to be resuscitated for, you got to resuscitate her before the fetus can be resuscitated. If there are no way whatsoever that she's going to live, like if you try to resuscitate her and it's not working, you keep those efforts until you get to the hospital. And they're going to have to maintain those efforts to deliver the baby if the fetus is viable. If a mother dies, within 5 minutes that fetus is going to die. So you can imagine how you don't have a whole lot of time at all.
So you're saying if there's like an obvious sign of death, as long as it's, I mean, obviously, if, she's like a rigor, there's
Yes.
nothing. But like, if it's recent, then you just work it regardless.
Work it regardless and go to the hospital. That way they can see if the fetus is viable. And they can do fetal heart tone to see if the fetus is viable or not. Bedside ultrasound to see. Having a mother lose a lot of blood loss, she's going to become hypotensive, tachycardic, she's not going to have enough circulating blood volume. So what's going to happen to the fetus? They're not getting good circulating blood volume, right? Because the mother's body is going to compensate for her. It's going to stop giving to the baby to compensate for her, because if she dies, the baby dies. Substance abuse, bad idea. Don't do it, right? Just say no. You will have those mothers who do abuse substance. Make sure that whenever you come up on a patient who is an obstetrical emergency or they're in active labor, that you ask them if you had any illicit drug use. If you used any marijuana, cocaine, anything like that, they might need to have some Narcan. Now, you wouldn't want to give a newborn Narcan because you're going to throw them into seizures. They cannot have any reversal agents. That's going to have to be maintained in the hospital setting. All you're going to do for that fetus once they come out is ABCs and transport. I think the dose for Narcan is what, 0.01 milligram per kilogram, something like that. We'll get to that in neonate, but you don't want to give them anything. You want to give them to the hospital. What is supine hypertensive syndrome?
Go ahead and tell me.
Baby's weight falls on the vena cava.
Right. If the mother lays down flat, then the fetus lays on the vena cava, which takes blood where? Takes blood to the heart, right? They're going to lie on the inferior vena cava. It's going to take blood to the heart. Well, if they're blocking that, blood flow is not going to get to the heart. What's the mother going to do? They're going to die, right? They're going to become very hypotensive. They'll complain of dizziness, lightheadedness, feeling fatigued. You need to roll them on their left lateral recumbent position. Management, put them on their left side, treat them on underlying causes, which most of the time, the supine hypertensive syndrome is because they are laying down flat. So once you roll them on their left side and give them some oxygen, they're going to be fine. Cardiac conditions, determine the nature and treatment of any heart condition they might have. Do they take any heart medicine? Do they have any underlying arrhythmias that you need to know about? Have they had a problem with rheumatic fever? What does that matter? What is rheumatic fever? It's an illness, it's a childhood illness that you can get, and it can cause cardiomyopathy. It can cause heart problems. If they've gotten that, then you want to make sure that you know that they've got a heart problem. Do they have any congenital heart defects? Have they had any dizziness or lightheadedness? Do you need to put them on an ECG and monitor their heart rate and their rhythm? Cardiac arrest can occur in pregnant women for a number of causes, whether it be cardiac-related issues, respiratory-related issues, trauma. Most of your life-saving drugs are category A and B. And if you have a mother in cardiac or respiratory arrest, you're going to do everything you possibly can for her. It doesn't matter what drugs you got to give her to save her life. In a cardiac arrest, you want to give high-flow oxygen, fluids wide open. There's all that. Aggressive resuscitation is justified in patients who are near term. What this means is if you cannot save her life, get her to the hospital, because within 5 minutes of everything being cut off of her, the fetus can die, so they're going to have to do an emergency C-section at the hospital to get the baby out. There have been times where paramedics have had to do an emergency C-section in the field to get the baby out to save it because the mother was dead. You know what, nothing they could do. I don't want to have to do that.
You just call, I guess you call med control.
And they tell you to come up, all you got to do is slice them open and
So are there no legal ramifications on that? Is that not, I mean, it seems a bit out of our scope of practice.
It really is. But I mean, you got to think if that's what's going to happen to save that baby's life, medical direction tells you to do it, then you're covered.
I mean, if you're on the interstate.
So it's under that,
Can't hurt anything.
it's under that doctor's medical license,
Yeah.
it's not
Right. Because who's ultimately responsible for what you do?
yourself.
Medical direction is ultimately responsible for you. You work under their license. This is a picture of left lateral recumbent position. Now, if you need to do CPR on a pregnant female, where are you going to do that? Yeah, she's laying on her right side. Really should be on the left side.
It's a mirror.
It's mirrored image. There you go. That's what it is. It's a mirrored image. It's actually her left side.
It doesn't matter.
It's her left side. You didn't know this was your left?
No, I didn't, 'cause I always do
It's your
this
left.
to make sure. L for left.
This is just an example of how to tilt the backboard. Does that make you feel better?
Nope.
All right, now if you're going to do chest compressions on a female, pregnant female, where are you going to do them at? You're going to do it higher up on the sternum than you would a regular normal person. Normal people, you do it right in between the nipple line, right? Right above the sternal notch. On a pregnant female, you're going to have to do it just a little bit up higher. Why is that? Everything's shoved up. Complications during pregnancy, they can have hypertensive emergencies, such as preeclampsia or eclampsia. We're going to talk about both of those here in just a few minutes. Gestational diabetes, they can be at risk for infection, neuromuscular disorders, cardiovascular disease. They can also be at risk for acute appendicitis or acute gallbladder disease, cholecystitis. Well, now wants to be 9 months pregnant and haven't had my appendix removed. Just scary, isn't it? They are at risk for those things as well. Hyperemesis gravidum, what is this? Excessive vomiting is all it is. Hyperemesis gravidum, hyper is a lot. Emesis is vomiting, so it's a lot of vomiting during pregnancy. It's all hyperemesis gravidum. It's excessive vomiting. Usually begins 2 to 5 weeks after conception. About 10% of mothers will have nausea and vomiting until delivery. It's usually less severe. Hyperemesis gravidum is there's no medication helping and they're constantly throwing up. Puts them at risk for dehydration. They get dehydrated, what's going to happen to the fetus? It's not going to get the nutrients it needs either. Cause is unknown. Not really what sure exactly causes it. It can lead to dehydration, weight loss, malnutrition. They're going to need antiemetics. What's an antiemetic that you can give on the truck? What's the dosage? 2 to 4 with a max of 8. They're going to need rehydration with fluids, isotonic fluids. What's an isotonic fluid? Almost saline. They might need vitamin and mineral supplements. That's not something that you're going to do in the field. These patients all of a sudden might need antidepressants in the hospital setting. Why is that? Could you imagine constantly throwing up? What toll it takes on your body? Pre-hospital care of these patients is primarily supportive. What is RH sensitivity? We say a mother's RH negative or just RH positive. What does that matter? It's the baby's blood and the mother's blood. What this means is you've got antibodies floating around in your blood. You either have positive antibodies or negative antibodies. And if you are a negative mother, if you have R negative blood, you have to get what they call a RhoGAM shot to help protect your baby. Because if you have a baby that is positive blood, has positive antibodies, your negative antibodies can go and attack that baby and kill the fetus. You don't want that to happen. That's why you have to get this RhoGAM shot. So all I want you to know about RH sensitivity is if a mother's RH negative, she's got to have what they call RhoGAM to help protect against the fetus. You can have, that's why if they say O negative, can go to anybody. So anybody can have negative blood. Alright? Not everybody can have positive blood. O negative people can give to anybody, but they can only take what? They can only have O negative. I luckily am O negative.
So am I. Saved my life.
Awful. I will save your life if you save mine. With RH sensitivity, you get a shot of RhoGAM at about 26, 28 weeks, and you get it again after delivery, so that your body doesn't develop those antibodies. And that's only if your fetus test, or only if you have a possibility to have a positive child. Like my husband is positive. He has positive blood, and I have negative blood. So I had to get RhoGAM with all of mine, including my miscarriage. I had to get a lot of RhoGAM shots. That don't make hurts too. They give it to you in your sub-Q tissue, like back in the back of your arm or in your thigh or your belly fat somewhere, and that hurts. It's a very painful shot. It burns. After. Alright, pregnancy-induced hypertensive disorders. A patient can be normally hypertensive. That doesn't mean they're going to get preeclampsia or eclampsia. It just means they have to have their blood pressure monitored. Other women can develop hypertension during pregnancy. What is preeclampsia? Preeclampsia is a triad. Did we ever talk about that in advanced EMT? It's a triad. They're going to have 3 things. What is it?
High blood pressure.
They definitely have to have swelling, and they definitely have to have what else? What's happening in their pee? Protein in the urine. They definitely have to have those two things. But the third thing they can have is high blood pressure. Now, not all preeclamptic patients have high blood pressure, but that is the third final thing with preeclampsia that can lead to eclampsia is the high blood pressure. Now, what do I mean by eclampsia? What has to happen for them to go from preeclampsia to eclampsia? Seizures. What can they get for seizure activity? Valium. Oh, I just popped it out of here.
Ooh, you broke it. Now we're not gonna have any sound ever again.
Where does it go?
It goes in that one.
I get electrocuted.
It's been broken, and it was barely hanging on.
Oh, and it's actually plugged into where the audio part goes, too. That's not good. I gotta give up. I'm sorry. I'm hoping it still works. We'll have to listen to the video and see if it still works or not. Hypertension can be mild or severe. It's mild or severe if it exceeds 110 milligrams of mercury diastolic. Factors: advanced age, if they already have chronic hypertension, if they have any renal disease or vascular problems such as lupus or diabetes. We already said this. Preeclampsia turns into eclampsia when they have a what?
Seizure.
They have a seizure. Sorry, I got this. I'm not going to go back to that again. What do you do to manage eclampsia? Do you treat the high blood pressure? No. Do you ever treat high blood pressure out in the field? No, you really don't. You have labetalol. You have nitroglycerin, which will help with blood pressure, but do you ever give that for blood pressure issues in the field? No.
Not directly.
Why you carry labetalol? I don't know, because I mean, really the only thing that labetalol is really good for is blood pressure control. Unless medical direction tells you to, because you're so far out. Pre-hospital care is directed at preventing and controlling seizures and treating the hypertension under direction of medical direction. And they're going to tell you just to bring them into the hospital. You're not going to treat the high blood pressure. Somebody having a seizure, you're going to handle them gently, minimize sensory stimulation. If they start to seize, you're going to protect yourself as well as the patient. You're not going to put anything in their mouth, don't put anything in their way. Leave them alone. Try to help manage their airway as best as possible. What is the #1 treatment for eclampsia with seizure? MAG. Magnesium sulfate is the best choice. They can have Valium and Ativan, but it can cause fetal distress. So the main drug you're going to give for eclampsia and seizures is MAG sulfate. All right, get your clickers. How much MAG sulfate are you going to give? Between OB, peds, and neonatal, there are a lot of drugs that we're going to go through, and dosage-wise, I suggest you know them. Correct answer is A. 1 to 4 grams of a 10% solution over 3 minutes. That's how much MAG sulfate they're going to get. 1 to 4 grams of a 10% solution over 3 minutes. That's just something you got to know. All right, magnesium sulfate can cause respiratory depression in your mothers, resulting from magnesium toxicity. All right. What is a reversal agent for magnesium toxicity? Calcium chloride. What else is calcium chloride good for? Calcium channel blocker overdoses, beta blocker overdoses, and now magnesium overdoses. Okay? A Motrin or ibuprofen overdose? Calcium chloride? I don't know. Yeah, I don't think that's calcium. All right, gestational diabetes. Main thing to worry about with diabetes in the pregnant female is their blood sugar too high or too low. If it's too high, what are you going to do with them? Give them some fluids and send them to the hospital, right? Take them to the hospital. Why would you give them fluid? What does hyperglycemia cause? Dehydration. Dehydration in a mama with a fetus inside her belly is bad. Bad news bears, okay? Give her some fluids and transport her to the hospital. What if she's hypoglycemic? Give her glucose. What kind of glucose? Depend on how low her blood sugar is and what's going on with her. You know, if she's conscious and has a good gag reflex, you can try oral glucose. You got an IV line, and she's ultramental status, you can give her IV dextrose, right? What percentage of IV dextrose are you going to give? 10%, 25%, or 50%?
You get the baby 10.
How much is in that thing of glucose? Just regular glucose. How much is it? 50%, right? You give 25% to who? Pediatrics. You give 10% to infants. Infants is anybody under the age of 1. Pediatrics is 1 to 1 to level of maturity. Like if they start to have breast or underarm hair, then they can be considered in the adult category. Depending on how much they weigh too. That's what I meant, puberty. Thank you.
We still have pediatrics if you investigate.
Treatment of diabetes is maintained with diet control and exercise. Gestational diabetes will not turn into type 2 diabetes later in life. Is this true or false? It is false. It has the potential to turn into type 2 diabetes later in life. That doesn't mean that it will, but it does have the potential to. HIV infection, this can be dangerous for the baby. There have been cases where HIV mothers have given birth to babies that are not HIV positive. It's kind of weird how that works. I would hate to have to take that risk if I was HIV positive. I would be afraid I'd give it to my baby. But the baby can get HIV infection through breastfeeding, which is why HIV mothers do not breastfeed. It can also happen during delivery. There's a lot of that blood exchange of fluids down that area. It also can be given to the baby during pregnancy. But there have been those studies where they have found that the mother has actually given birth to a perfectly healthy baby. I don't remember what the percentage is. It's like,
I wouldn't say
it's a pretty good percentage. It's like
more than you would
80%.
think,
Yeah.
Yeah.
It's like, I think it's like 19% of mothers give birth to HIV positive babies.
Yeah, I mean,
With all the medications they have now.
It's a lot higher than you think.
Sexually transmitted infections, we already talked about bacterial vaginosis. If that happens during pregnancy, it can cause low birth weight, premature infant, also cause PID. Yeast infection is very common during pregnancy. Very, very, very common during pregnancy. Can happen when they take antibiotics. Like if a mother's got a really bad cold, she takes a set of antibiotics. 9 times out of 10, your OB doctor will also put you on diflucan, which is treatment for yeast infections, because antibiotics will cause a pregnant woman to get a yeast infection. Chlamydia, now ain't nothing gonna cause chlamydia except sleeping with somebody nasty. Okay. It is a nasty sexually transmitted disease, and it can cause blindness in your baby. So can gonorrhea. Yeah.
Just a while ago, talking about these medications that prevent like HIV going into the baby. What about like hepatitis C? Is there anything for that?
No.
No, you get it. Your baby has it.
Your baby's more likely, it's just like healthcare providers, you're more likely to get hepatitis B or hepatitis C from needle stick than you are to get HIV.
Oh, yeah, that's all
Isn't that weird?
worried about. Really.
I always thought, when I first came into the healthcare field that, you don't want to mess anybody who has HIV. You don't even want to touch them. But people who have hepatitis B and C are more deadly to you than HIV patients are. Chlamydia can go anywhere in that downstairs area. Can progress to pelvic inflammatory disease. Gonorrhea is another sexually transmitted disease. Both of these cause purulent drainage, foul-smelling odor. Both can cause fetal blindness. If the baby comes out, they can have fetal blindness. HPV can cause warts. Patient can be asymptomatic. These can develop laryngeal, which is basically just a laryngeal warts. Syphilis, patient can be asymptomatic for years. Syphilis can just be, can remain in the body for years. It shows up, first off, the heck was that?
I didn't hear a crunch after
It did sound like an alien. I thought it was like a spaceship coming to us all the way. Get a little worried. What did you say?
I said I was from my butt. I want to get frozen.
Remember that?
What's the first stage of syphilis? They usually have a little single sore. Where is it located? palms of the hand and the soles of the feet. Why located there, I have no idea. They get a little skin lesion there, a little skin sore that turns into a lesion. They'll start having a rash, sloughing of the skin. And later it attacks the body. It can attack the liver, the kidneys.
Doesn't it do something with your brain?
It can mess up your brain, yeah. Cause you to have ultramental status, especially if it's not treated.
That's like long term.
And kill you, yeah. Long-term syphilis. Women with syphilis can have stillborn babies. Their babies can be born blind. Babies can die shortly after birth. They're underdeveloped. Trichomonas is another vaginal STD that is nasty. It's probably one of the nastiest. It produces this brown, nasty, yellow drainage that's very foul smelling.
Under a microscope? What it looks
No.
like?
I see enough of it pouring out in the
It
ER.
looks like tadpoles.
It's gross.
It's the-
Can also cause dysuria. What's dysuria? Difficulty urinating. Dysuria. Difficulty urinating. Also cause lower abdominal pain. These patients can have premature births. Their babies can be low birth weight. Another set of infections is known as the torch infection. This is toxoplasmosis, which is what? How do you get toxoplasmosis? Cat litter. The cat poop. When the cat scratches, they can release toxoplasmosis. That's why they say pregnant women do not need to be around litter boxes at all. At all. We had a cat when I was pregnant with Logan. And that was my reason for not changing the litter box. I hate that thing on cat too. Other infections, hepatitis B, syphilis, herpes, all these things can cause problems with the babies. R is rubella, known as German measles. You have cytomegalovirus and herpes simplex virus, causes genital herpes. All those are here that you can read about. But they can pass on to the baby, cause a lot of problems such as miscarriages, congenital heart defects, blindness, rash, cause anemia, low birth weight, jaundice. I mean, anything possibly could go wrong with the baby. All these types of infections can cause it. How do you not get those? Well, you get your vaccinations, you practice safe sex, and good personal hygiene. And you stay away from litter boxes. And cats. I hate cats anyway. Bleeding problems during pregnancy, we're going to talk about all of these. Spontaneous abortion, that is a miscarriage. Patient can have sudden onset of abdominal pain, vaginal bleeding. This happens, you want to ask if they've noticed any tissue, if they've noticed anything coming out with the bleeding, how many pads have they gone through. Ectopic pregnancy we've already talked about in length, we're not going to talk about that again. What's abruptio placenta?
Spontaneous trauma, I guess.
Spontaneous tearing or pulling apart of the placenta off of the uterine wall, right? This is where the placenta detaches, can cause extreme abdominal pain, vaginal bleeding, depending on where the placenta abruptio took place. If it's high up or if it's down low. If it's down low, you're going to have what kind of bleeding? Bright red bleeding. If it's up high, you're going to have what kind of bleeding? Maybe none. Maybe just have a rigid abdomen, or you're going to have dark bleeding. All right, that can happen mainly from trauma, like Ryan said. It's usually from assault, patients who fall down the stairs. What about placenta previa? Where the placenta attaches over the cervix. Now, they're going to know this if they've got good prenatal care because they can tell this in an ultrasound. And they can have vaginal bleeding throughout. Can you deliver a baby vaginally if you have placenta previa? No. I can't deliver a baby through a placenta. All right, what about uterine rupture? They are going to have extreme abdominal pain. This is from almost like an abruptio placenta, can come from trauma, but it can also come from patients who've had C-sections who are trying to have a vaginal delivery. That uterus itself just ruptures or tears, and they'll complain of a tearing sensation. They might not have any vaginal bleeding at all. They're mostly going to have internal bleeding, which is going to show up with a rigid abdomen. All right, postpartum hemorrhage is a blood loss of how much? Over 500 milliliters, which is what? Bag of saline, what, 1,000? So half that. Really, when you see a delivery for the first time, it looks like there's a lot of blood. I mean, it looks to me like way more than 500 milliliters, doesn't it?
Yeah.
It's a good bit of blood there. All right, as the mother loses blood from the vaginal hemorrhage, what effect does it have on the fetus? What will it do to the fetus? Oh, I didn't mean to hit it. I'm sorry. I know y'all are probably just like, just shut up and stop talking, aren't you? Y'all ready to go eat? I know. I don't know that I can make it anymore either. All right, so if the mother starts losing a lot of bleeding, starts having a lot of bleeding, the baby can go into distress and possibly die. Of course, they're not going to cause 100% delivery all the time, and the fetus will not be compensating. They're going to die. All right, loss of pregnancy before 20 weeks is known as what? I know, it's hard. I don't like that A word either. It is a spontaneous abortion. What's abruptio placenta? Tearing of the placenta. Detaching is actually the better word. Detaching of the placenta from the uterine wall causes really bad abdominal pain. Now, placenta previa, do you have any pain? No. No pain with placenta previa. We already talked about this. What do you do for somebody having a spontaneous abortion? Comfort measures, IV, fluids, emotional support. Emotional support's easier to come by for women, I think, than it is for men. I know whenever we had our miscarriage, I took it a lot harder than my husband did, of course, because I mean, it didn't happen to him, but it did happen to him in a certain extent because it was his baby too, but it takes a really big toll on the mom. So make sure you do a lot of emotional support and be very empathetic. Huh?
A lot of times they feel like it's their fault.
They do. They feel like it's their fault. But, you know, there are, unless you are just having the most riskiest lifestyle ever, if you're a normal person, it's nothing that they're doing that's causing this. Medics are called at home an 18-year-old female who complains of right lower quadrant pain and scant vaginal bleeding. What do we mean by scant vaginal bleeding? Very little, right? Spotting. Patient says she thinks she started her cycle but is unsure because she has been very irregular. Patient denies fever, also complains of nausea and vomiting. She is tender in her right lower quadrant. What medical condition does this patient possibly have? A nice little registry type question for you, and then there's two nice answers, but only one's correct. Only one is better. Yes, I should say. Possibly, she has an ectopic pregnancy.
No fever gives away.
No fever. Well, I didn't have a fever when I had my appendix out. I didn't have a fever and I didn't have an elevated white count. All I had was nausea and right lower quadrant pain. So
I had like
no fever, nothing.
stomach pain with nothing else.
Yeah, I just had abdominal pain and nausea. That was it. But if she's been very irregular, she's in that childbearing age, she more than likely has an ectopic pregnancy versus a appendicitis. Kidney stones is not even in there. We already talked about ectopic pregnancy and length a while ago. I'm not going through that again. Third trimester bleeding, we talked about abruptio placenta and placenta previa and uterine rupture at length. What do you do for all of these? Treatment's pretty much the same for all of them, right? Comfort measure, IV, fluids, and transport. Okay? Comfort measure, IV, fluids, and transport. Partial or full detachment of the placenta from the wall that is extremely painful, and the patient will have dark red vaginal bleeding as well. What is this called? Abruptio placenta. Predisposing factors, these patients, trauma, of course, is the main cause of abruptio placenta. Placenta previa, we've really already talked about this too. I'm not going to go through these again. Y'all are okay with that? Uterine rupture, we just talked about this as well. Management, try not to examine it. You want to get them to the hospital as best as possible. Now, the medical control might tell you to push the uterus back up in there. I'm sorry, that's uterine inversion. This is uterine rupture. Excuse me, I apologize. With uterine rupture, you're just going to need to pad the area and transport. Give them fluids and monitor. All right, I'm going to stop this right here because I think all y'all are about dead. You are?
Hey, we've got less than 100 slides to go in this PowerPoint.
There's only two more chapters.
And only 2 more PowerPoints after this.
That's such a nice way to look at it. All right, let's start with labor and delivery.
Yay!
Yay! All right, what is the first stage of labor?
Pregnancy.
Contractions. What happens? What is happening when the body is contracting? When the uterus is contracting, what's going on?
Babies are trying.
Why is it contracting? What's it making the cervix do?
Dilate.
Thin and dilate. That's the first stage of labor. All right. So the first stage of labor begins with contractions and effacement of the cervix and ends with what? What does it end with?
Baby.
You got a clicker?
Oh.
Pay attention.
Sorry. Didn't know that was one of the answers. Help if I read.
Anybody heard from Kane today?
Yeah,
He has to work.
yeah, his work schedule didn't get changed. Yeah.
Obviously, he didn't know how to text you, but I asked him.
Obviously he didn't.
Obviously,
You just people on the
stay
school
away
about
from
don't
people.
The correct answer is complete dilation of the cervix. So it starts with contractions and effacement and ends when the cervix is completely dilated and you're ready to, and the baby's starting to come out. That's whenever it stops. Complete dilation of the cervix. Doggone it. Contractions usually progress over a period of time. They go from 10 minutes to 7 minutes to 5 minutes to 1 minute. They get stronger and stronger and stronger. Women can also have what they call Braxton Hicks contractions. What's the difference between a true labor contraction and a Braxton Hicks contraction?
The Braxton Hicks contraction is annoying, the true ones actually dilate the cervix.
Right, the Braxton Hicks are just slightly painful and they're very irregular. They are not regular at all. That's how you tell the difference is their regularity. They are not regular at all. Some can be intense, others can be very mild. But a true contraction stays on a regular basis. It goes from 10 minutes to 7 minutes to 5 minutes to 1 minute apart, and they get intense, more intense with each contraction.
So, if you're having the Braxton Hicks, the only way to know
To monitor them and make sure that if they're getting worse and worse and worse and worse and worse, and they're on a regular timed interval, then they're probably true contractions. But if you have one, then 5 minutes later you have another one and it's not as bad, then 2 minutes later you have another one but it's really bad, that's probably Braxton Hicks. But 98% of your pregnant population will go to the doctor just to get double checked. All right, what comfort measures can you use during transportation for a patient who is in the first stage of labor?
Position.
Put in position of comfort. What else?
Star line, you're gonna need one anyway.
IV, you're going to need one anyway, some fluids. That way they can get some pain medicine maybe. If they need any at the hospital setting. Can't put in an epidural, can you? No, you want to send that. What about oxygen?
Yes.
Yes, oxygen. All right, second stage of labor is measured from full dilation of the cervix to delivery of the infant. So the cervix is completely dilated. The baby starts to come out. Once the baby is completely delivered, that ends the second stage of labor. So what does that mean the third stage of labor is? Placental delivery. Okay? How can you tell if your patient is in imminent delivery?
You see the baby?
They see ahead. What are they going to tell you?
Yeah.
They feel they got to poop, right? They got to have bowel movement. They feel like they've got to bear down. I feel like the baby is coming. So they're going to tell you. How do you prepare for a delivery? What do you do? You pray. Right, number one, we pray. Okay? Second, what do we do?
Put ourselves on.
You act like you know what you're doing.
Pray to God that you know what you're doing. And you've got to act like you know what you're doing. You don't want to be fumbling through some things and you're like, oh my God, I don't know what I'm doing.
Don't act like you've never seen an OB kit.
Don't act like you've never seen an OB kit.
Don't ask where it's
Which, how many people are going to take that OB kit, open it, and start dumping stuff out everywhere? Freaking out. It's going to be Sam and Kimberly. They're going to start doing that. Cameron's probably going to do that too, right? Start dumping stuff and freaking out. All right. The different place. What about different places for delivery? How do you just set a mother in a car to deliver? Where's the best place for that?
Back seat.
Back seat. What are you going to do to legs?
Up on the back.
Throw them up, like on the back of the front seat, and maybe up on the back of the back seat, and that way. We want to kind of far apart and have somebody behind her kind of holding her up. All right. What about at our home? Where's the best place there?
Ambulance in the driveway.
Ambulance driveway. Would be a really good place. Ambulance would be a great place to deliver a baby, right? A couch or a bed or even the floor or something where she's got some padding back behind her. All right. How do you deliver a baby?
Tell her to push.
Like this?
You catch.
Get your baseball glove, get your catcher's mitt, get ready and give catch, right? Get ready to catch? Okay. Let's talk about how to deliver a baby.
Oh, there's way too many pictures on this slideshow.
Okay, shh. Get over it, y'all. Act like you've never seen a vagina before. Once the head is crowning, you're ready for delivery. put your hand, of course, on the baby's head to help kind of hold it there steady. You don't want it exploding out, right? We don't want a precipitous delivery. We don't want it exploding out, because what happens if the baby explodes out?
You drop them.
You can drop them. That's a really important thing. You can drop them, but it can also cause trauma to the baby and trauma to the mother as well. All right, next you deliver the head, and you don't really need to do anything. This baby's going to come out on its own. But when the head comes out, what are you going to look for? Or what are you going to feel for?
Make sure the cord's not right.
Make sure the cord's not wrapped around the neck. What's that called? Nuchal cord. All right, once the head is delivered, you are going to suction. What are you going to suction first? Suction the mouth first, and then the... We don't eat our boogers, pick our nose and eat them, right? We don't eat our boogers. All right. Once the head is out, the shoulders are the next thing to come out. You might have to sit there and kind of rotate your baby just a little bit, rock them back and forth to get the shoulder out. But once one shoulder's out, you rock them another way and get the rest of the shoulder out, okay? Or the other shoulder out. And that was it. That's all I got. I didn't get the end of it. All right, once the baby comes out, what are you going to do? Cut and clamp the cord. Where are you going to cut the cord out? Where are you going to clamp the cord at is what I meant to say. Huh?
The middle.
5 to 7 inches, and then what? 2 to 3 behind that? Back or this way? You're going to clamp? Are you going to have to check sensation or pulses in the umbilical cord? Check for a pulse. Once that's stopped, then you clamp and cut, correct? Once the cord is clamped and cut, what do you do with the baby?
Dry it off.
Dry them off. Dry them off, warm them up, stimulate them. During this time, what are you doing? Your 1 minute mark. You're doing an APGAR. What are you doing? When do you do a second APGAR? 5 minutes. All right, what is APGAR? Let's talk about that. All right, A is for appearance. So appearance, what do they look like? Are they blue all over? Are they pink all over? What if they're blue in their extremities? What's that called? What's the A? Huh? What'd you say? What'd you say?
I didn't know it said something that started.
Are you sure?
Yes, I'm sure.
What did you say then?
I thought you did. Acrocyanosis. You remember that word now? Acrocyanosis is bluing of the arms and the legs. And about 75% of your babies are going to come out with acrocyanosis. All right, what's P? Pulse. What's their pulse need to be? 120 to 160. All right, what's G? What does that mean? How do they appear? Are they crying? Are they screaming? Are they quiet? If they're crying and screaming and very active and loud, how's their respiratory rate? Respiratory rate's probably really good, right? All right, what do you want their respiratory rate to be? That's what R is, by the way. I know we kind of skipped G. What is their respiratory rate? 40 to 60. Okay, 40 to 60. What does the other A stand for? Activity. What does that mean? How much they move their arms and their legs. If you grab a baby's arms and they're stretched like this, if you grab them and pull them out, what are they going to do with them? Pull them right back. Because how much, what kind of position have they been in? Fetal position. So they've been, their arms and legs crept up. So you pull them out, stretch them out, they're automatically going to go back. Now what's a moral reflex?
That's the
That's palmar reflex. Moral reflex is the startling one, where you got to act like you're going to drop them, and they do this whole thing where they like start bending their arms and their legs, and like they're going to fall. All right, how many points do you give for APGAR? How many points they get per one? Per one. They get 2 points per one. Max score of 10. Minimum score of 0. If they're stillborn, they're probably going to be a 0, right? If they're a normal, healthy baby, they're going to be anywhere between 8 and 10. All right, after they are born, if they have an APGAR of, less than 6, I think, they might need resuscitation measures. How are you going to put them in a neutral inline position? What are you going to do to their shoulders? Pat them under their shoulders, because the back of their head is usually really large, right? So it kind of cuts off their airway. All right, criteria for communion APGAR score, we just went through that. Let's calculate one together. Newborn infant who is crying, arms and legs are flexed, heart rate of 140, and a respiratory rate of 55. and they have acrocyanosis. Has an APGAR of what? All right, so if they are, what's their appearance? They have acrocyanosis. So how many points do they get? 0, 1, or 2? They get 1. Why? Because they're blue in their extremities. If they were blue all over, how many points would they get? 0. All right, pulse is 140. Is that normal?
Yes.
All right, so what do we get there?
2.
All right, grimace. What do we say about their grimace? They're crying. Is that good? We want our babies to cry, right? All right, what about activity? They're flexed. Is that good or bad?
Good.
What if their arms and legs were extended? That's bad. They get a 0. All right, so we get a 2 here. All right, respiratory rate is 55. Is that normal or is that too high? It's normal, right? So they get a 2. So what's our total? 9. We got a pretty healthy baby? Yep. And probably by 5 minutes later, the acrocyanosis will disappear, and we will have a baby with a score of 10. 7 and 9 indicates the infant is slightly depressed, near normal, and if they're about a 7 or 10, usually it's going to have to do with grimace and respiratory rate. Those are going to be the 2 main ones that are going to cause you some problems. If they're not crying and they're not breathing adequately enough, stimulate them. How do we stimulate them? Do we shake them? Do we put them upside down and tap their tushy? Yeah, no, we don't. What do we do with them? Rub them, vigorously rub them, pat their feet, thump the soles of their feet, stimulate them that way. Also keeping them warm. If you have an infant who has a depressed respiratory rate, warm them up, stimulate them and warm them up. Because that's how they become hypoxic, is they get cold and they get very, very sleepy and they start getting really cold and they're not warm at all, become hypothermic, and they will have a depressed respiratory rate. All right, 4 to 6 indicates the infant is moderately depressed, which means there needs some type of resuscitation measures. And the first thing that you have to do as far as resuscitation goes for these neonates is stimulate them and warm them up. That is the first thing you do. Stimulate them, warm them up. If that doesn't work, they get flow by oxygen. If that doesn't work, then they're going to need intubation. Okay. Already talked about that. How do you deliver the placenta? Massage the fundus if they've got some bleeding. That's why you would do that. Placenta usually comes in about 5 to 30 minutes after delivery. You sit there and pull on the cord? No. All right, what if the placenta does come out? What do you need to examine it for? Make sure it's all there, right? Make sure there's no chunky pieces missing. And then evaluate the mother. And if she's got some excessive bleeding, you can massage the fundus, but what else can you do?
Nurse.
Give the baby to the mother, let her nurse. Postpartum hemorrhage is characterized by how much of a blood loss? More than 500 milliliters. If fundal massage does not work and nursing does not work, you can give oxytocin. Do I have oxytocin on the truck? Nope. No, you don't. It is one of the drugs that you can give, but most ambulance services do not carry it on the truck.
Now, do we wait for the placenta to...
No, you do not have to wait because it can take up to 30 minutes or even 45 minutes for the placenta to deliver, so you could load the patient and the baby up and take it to the hospital. Right. All right. If you did carry oxytocin on the truck, since it is a national registry drug, how much did you give for a postpartum hemorrhage? You can give it IM. Did you know that? You can give it IM or IV. If you needed to give some IM, how much would you give? Correct answer is 10. 10 milligrams IM. What are some complications you can have during delivery? You can have a nuchal cord. How do you fix that? Put your fingers up under the cord, kind of loosen it up a little bit, and gently slide it over the baby's head. What if it's too tight? Huh? Yeah, no. Try to see if you can get your fingers under it to get it relieved, but if not, then you're going to need to clamp it and cut it. clamp and cut the cord. All right, what about another complication you can have? Your mother states that her water just broke and she feels like something's coming out, and when you examine her, you notice that the umbilical cord is hanging out. It's known as a prolapsed cord. What do you do?
Oh, you pregnant?
Right, you put her, what position do you put her in? Huh? They can put them in that, it's not really. Put them on their knees. And what are you going to have to do with your hand? Insert a gloved hand into the vaginal area and relieve pressure on the umbilical cord by pressing on the baby's head, right? You don't want that head pressing against the umbilical cord, because if the baby's head pressed against the umbilical cord cuts off oxygen and nutrients to the baby, how many minutes do they have to live? Like 5. So you don't want to do that. Pre-hospital care for all mothers is safely delivery of the baby, care of the baby, oxygen, IV to the mom, fluids as needed. You can also have cephalopelvic disproportion. What this means is the head does not match the pelvic area. All right, the head's too big for the pelvic area. This can happen a lot in your smaller women that carry full-term infants. They cannot deliver because their pelvic bones are too small. And you don't want to have a crushed pelvis trying to deliver a baby. It's not going to work. So what they have to have done is a C-section. What they would tell you is they feel like they're in labor. You check, make sure there's nothing coming out, and you transfer them to the hospital. Oxygen administration, IV, fluids, and rapid transport. Because they're going to have a C-section. Reach presentation. How can a baby be reached? What can come out?
Feet first.
Feet first or the butt first, right? Occurs in 3 to 4% of deliveries at term. More frequent in multiple births. Categories: you can have a frank breech where the fetal hips are flexed and the leg stands in front of the fetus. That's A. Okay? Then you can have a complete breech where the fetal has both knees and hips flexed and the buttocks is presenting. Or an incomplete breech where fetus has one or both hips incompletely flexed and they might have a foot sticking out. Could you imagine pulling something back and looking and there's a foot dangling out? That would be very uncomfortable to have to deliver that baby, I would think. Would not want to deliver a baby that way. Babies can be delivered breech, but you can have some complications. If the feet and the bottom area come out first, what happens when the chest comes out? What's the baby going to do? It's going to breathe. It's going to take a breath. If they're trying to take a breath, whenever their head is stuck in the vaginal area and their mouth and nose is up against the vaginal area, what are they going to do? They're going to aspirate. They're going to suffocate too. So what do you have to do with your hand?
Put it over their face.
Give them some room. Put it up in there in front of their face and make this V shape over their nose and their mouth to kind of relieve the pressure so that they don't get a suction effect to their face. If delivery is imminent, you want to prepare the mother for delivery as described earlier before, which you would put them in a regular position. So at this time you would want to have someone hold their legs up a little bit higher to kind of open that pelvic cavity up a little bit more. Provide oxygen. Allow feeders to deliver spontaneously up to level of umbilicus. If they're in frank breech, try to grab the legs and pull downward as best as possible to get them to come out that way. And as we said earlier, once their chest delivers, they will take a breath, so you want to put your hand in there to help make sure that they don't get that suction on their face so they don't suffocate. If head does not deliver immediately, action must be taken to prevent suffocation. We just talked about that. All right, what's shoulder dystocia? Shoulder dystocia occurs when fetal shoulders are wedged against the maternal symphysis pubis. They do what they call the turtle effect. Their head comes out and their shoulders wedge in, so they duck back in. Okay, this can be very painful for the mother. It can be traumatic for the baby. These patients might have to have a C-section. The baby might wind up having a brachial plexus damage. What is that? The brachial nerve gets basically severed and they lose all motor function and nerve sensation in that arm. They can also get a fractured clavicle because they're trying to come through an opening that's not big enough for them.
So if they're already to that point, you wouldn't push them.
No, you usually have to deliver them. And at this time, you're going to manually have to rotate the shoulders and try to, you do what they call a rocking motion sensation. You know how used to they tell you when you thought you had a pelvic fracture, they tell you to rock your hips. They don't do that anymore. But these babies, you're going to have to grab a hold of their shoulders as best as possible and kind of rock them out to get them through the pelvic bones. They're going to come out. They have to come out. They're not going to be able to stay there and be stuck. They'll die. You leave them there. They got to come out. Try to deliver the anterior shoulder immediately after the head. What do I mean by anterior shoulder? Which one's that, left or right? Huh? The one that's first in the way. Doesn't matter if it's left or right. It's whatever's one that's presenting. You want to try to deliver that one first. And then you have to try to successfully maneuver the other shoulder to get it out. Best position for the mother is on her left side in a dorsal knee chest position. Helps to increase the diameter of the chest. Shoulder presentation results when the long axis of the fetus lies perpendicular to the mother. The fetal arm or hand may be presenting. How do you get this baby out? You don't. If a shoulder is presenting or an arm is presenting, you can't get that baby out. They're going to have a C-section, so you have to do rapid transport for these patients. Sit there and hold the baby's hand or do something, because I mean, you're not going to be able to get them out. You try to pull them out or rotate them, and you're going to cause a cervical spine break. You're going to kill them. Don't do it. This is a cesarean delivery. And sometimes the force of the contraction can be too much and can wind up breaking the baby's neck if they're positioned that way. Core presentation, we already talked about that. Don't need to go through that again. Other presentations, a face or brow known as the military presentation. The infant's head is delivered face up instead of face down. This causes what they call back labor. I've seen several mothers who said they have really bad back labor, and it's because their baby's face up instead of face down. This causes a lot of pressure and pain on the symphysis pubis and on the lumbar spine. Sometimes fetus has other associated abnormalities that may require a cesarean delivery. And they'll be able to tell you that if there's something on their ultrasound, if they've got something going on. They'll tell you, I'm supposed to have a C-section, I've got to get to the hospital right away. Goals of treatment is early recognition of potential complications, maternal support and reassurance, and rapid transport. What's meconium staining? It's when they poop. Meconium is the baby's first stool. And sometimes if a delivery lasts for a very long period of time, the baby can go into distress and can wind up having its first bowel movement in utero. And when that happens, that tar-like poop starts circulating around in the amniotic fluid. And what does that baby do with it? He breathes it in, right? That's what he does, the amniotic fluid, he breathes it in. That meconium is like tar. And if you've ever seen a baby's first poop, it is sticky and nasty and tar-like. It gets into the lungs, what's it going to do? It's going to stick there. It's going to keep the alveoli from opening or expanding and deflating, expanding and deflating. That's where gas exchange occurs, right? Is he going to be able to have good gas exchange? Is he going to have a good patent airway? No. What are we going to have to do for him when he comes out? If the meconium staining is bad enough and his respiratory system is depressed. He's going to have to be intubated and suctioned. All right? Fetal, I can't ever say that word, marcosoma. Anyway, it's a big baby. Usually happens with patients who have gestational diabetes. They have a very large baby. Usually it weighs more than 9 pounds. Cannot imagine having a 9-pound baby.
It's not fun.
These babies actually wind up coming out most of the time with a low glucose level. So we want to encourage the mom to feed and to nurse so that baby can get adequate glucose. Premature birth is an infant born at 37 weeks gestation, low birth weight, which is less than 2.5 kilograms or 5.5 pounds. Occurs in about 8 to 10% of all pregnancies. What are you going to do with a preterm infant? Same thing you can do with another one. Monitor their ABCs, stimulate them, keep them warm, encourage what we call kangaroo care, keep the baby with the mother, skin to skin, helps keep them nice and warm. And monitor any airway abnormalities because they're going to have problems with their airway if they're very premature. Suction any secretions. Your babies are obligate nose breathers, right? So if their nose gets stopped up, you think they're going to be able to breathe through their mouth? No. They don't start breathing through their mouth until they're about 3 months of age. So those first 3 months are really critical at keeping their nose good and cleaned out. Otherwise, they will suffocate to death because they're not developed enough to breathe through their mouth. This is an example of a newborn full-term infant. You can see how their legs and arms are flexed. And this is an example of a preterm infant. Nothing's flexed. Everything's just kind of flaccid. They're a lot smaller. Their heads are smaller. Little bitty babies. A lot of times if women are having early contractions and possible going to go into preterm labor, they'll be admitted into the hospital and have to get several different medications to help keep them from delivering. You just need to make sure that you ask moms. That'd be one of the things, have you had an uncomplicated pregnancy, or have you had a complicated pregnancy? Have you had to take any extra medicine? Things like that. Multiple gestation just means pregnant with more than one baby. Can you deliver twins out in the field? Yeah, you sure can. If you deliver one baby, you cut and clamp the cord and wait for the next one to start to come out. And you cut and clamp the cord and do the exact same thing as you would with just one. But you are more risk of having a breech baby the second time around versus the first. Do you have enough supplies in your ambulance to manage more than one delivery? Should have enough to manage how many? At least 2. Pray to God you don't have triplets. I would hope and pray that people will not deliver triplets at home, but you never know. Postpartum hemorrhage may be more severe after multiple births, so make sure you watch out for that and you already know how to fix that. A rapid spontaneous delivery with less than 3 hours from onset of labor to birth is known as what? The answer is precipitous delivery. What's the complication of precipitous delivery? Tearing, trauma to the vaginal area of the mother. What about the infant? Baby can have broken collarbones, scalp fractures. Results from overactive uterine contractions and little maternal soft tissue or bony resistance. Most often occurs in a mother who is grand multiparamine. She's got more than 2 children. She's got a lot. Like that lady, the Duggar lady, who's got like 30-something kids. Can be associated, of course, with a soft tissue injury and can also cause uterine rupture. The uterus is contracted so forcefully and it shoots that baby out very quickly. The uterus can rupture itself, or also can be caused to be inverted. What do I mean by uterine inversion? We talked about that earlier. How it just kind of turns out on itself. Goes through the cervix that way. Precipitous delivery can help by holding really good counter pressure on the infant's head. How do you do that? With your hand. Just hold pressure on the infant's head as they're coming out to keep them from exploding out. Let's talk about a uterine inversion. 9 times out of 10 uterine inversions, you can put your gloved hand in there and push it back up into the uterus itself. So all it is it just turns itself inside out and comes through the cervix. So you have to push it back up through the cervix. It can cause postpartum hemorrhage. Hypovolemic shock can develop quickly if you don't get the bleeding controlled. Pre-hospital care, ABCs, rapid transport, and medical direction might recommend that you manually replace the uterus. Only if the cervix is not yet constricted. Cervix start to constrict, you can be able to push that uterus back up in there.
So it strangulates the uterus too.
Uh-huh. They can wind up having, they will wind up having a postpartum hemorrhage. They bleed out. You have to give them lots of fluids and transport quickly. They have to have surgery, and they probably wind up having to have a hysterectomy. All right, what about pulmonary embolism? Can pregnant women get those? Yes. Yeah, pretty much anybody can get those, right? What do you do for pulmonary embolism with a pregnant woman? Treat it the exact same way you do everybody else, right? Left lateral recumbent position, large bore IV, fluids, vital signs every 5 minutes, rapid transport, oxygen. How much oxygen would you put on them?
All of 15 liters of breathing.
Oh, you have 15 liters now breather, right? What are they going to complain of? Shortness of breath, sudden onset of some chest pain. Heart rate would be tachycardic. All right, premature rupture of the membrane. Sometimes this can happen throughout pregnancy depending on how far along you are, if you had a traumatic event, how many children this is for you. Usually if that water breaks, within 24 hours you need to be delivering that baby. Why? Infection. Have a greatest risk for infection. Sometimes it will heal back on its own, and they'll have to give them preterm labor medication to help keep them from delivering. 24 hours, let's talk about that. Amniotic fluid embolism, just like an air embolism, amniotic fluid can enter the circulatory system and cause complications just like a PE would. What are you going to do for these patients? Left lateral recumbent position, IV, fluids, vital signs every 5 minutes, high flow O2, transport. Yeah, we're done with labor and delivery. Woo. Woo. Yay. Alright, let's talk about neonatal care. Alright, several things we just talked about with OB kind of spill into neonatal. They are at risk, mostly at risk for hypothermia. If they become hypothermic, what's going to happen to their heart rate and their respiratory rate? It's going to decrease, right? So we want to keep them warm at all times. Newborn or neonate care must be adapted to meet the needs of the population. The newborn is within the first few hours after birth, and the neonate is in the first month, which is about the first 1 to 28 days. Neonatal resuscitation is ABCs, as everything else is ABCs, airway, breathing, circulation. Newborn stabilization, you want to keep them warm. Position of comfort. How do you lay a baby down to sleep?
It changes every couple of years.
That's like it changes all the time.
You're supposed to lay on it.
Back is best, is what they say. They are supposed to be on their back. Because if they're on their belly, they can suffocate. Mine's been sleeping on her belly since she learned to roll over. Their face will suffocate on their bed. That's why they tell you not to put those bumpers in the bed either. Because they can get up to the bumper and can suffocate. We have a mesh bumper. We have a bumper, but it's a mesh bumper that is 100% SIDS proof. Additional resuscitation steps, supplemental oxygen, intubation, positive pressure ventilation, chest compressions, and lastly are medications that you would need during neonatal resuscitation. First breath is triggered by mild hypoxia and hypercapnia. What's that mean? What's their oxygen levels doing? Dropping. And what's hypercapnia? Retaining a lot of carbon dioxide. Alright, so if they're retaining a lot of carbon dioxide and they're hypoxic, we need to help give them some oxygen, give them some flow by, stimulate them and encourage them to breathe. It's going to help blow off all that extra CO2. This is just an example for you picture people who like to see pictures. Transition from a fetus to a newborn. How the heart defects, the holes in the heart close. And circulation is changed from the placenta and the umbilical cord to the arteries and veins in the body. Arrival of the newborn. First, obtain patient history and prepare environment. You want to keep the area warm, like this is the back of an ambulance. You make sure the back of the ambulance is nice and warm. Because you got plenty of blankets. Bulb syringe is very important. Why? Suction, because they are obligate nose breathers, right? Their airway gets occluded in their nose, they're not going to be able to breathe. 2 small clamps or ties. Nobody ever uses ties anymore. Just a clamp. And a clean pair of scissors, but your kit has a scalpel. Nobody's kit has scissors unless you're actually in the hospital. Once you deliver the baby, check their ABCs, suction them again if needed. Keep them warm, give them to the mom, kangaroo care. Where I talked about clamping the cord, we're not going to talk about that anymore. If the newborn begins to turn pink in the first 5 minutes, you want to continue to watch observation. If they are born with acrocyanosis, you might have to give them a little bit of flow by oxygen, stimulate them, keep them nice and warm. If they're full-blown cyanotic from head to toe, they're definitely going to need oxygen and stimulation. APGAR is done at how many minutes? 1 in 5. Max score of? Min score of? A stands for? P, G, A, R. Okay. This is the algorithm for neonatal resuscitation. It's in your book. You're welcome to look at that. If you have, I have a really hard time reading this at all. But if your baby starts to deteriorate at all, they become cyanotic, or they start to, their respiratory rate starts to decrease, or you notice their heart rate starts to decrease, you're going to have to stimulate them first and warm them up. That is the first step, stimulating them and warming them. And the second step is, if that doesn't work, what do you do next? Flow by oxygen. If that doesn't work, positive pressure ventilation. If that doesn't work, then they might need intubation, right? What if their heart rate drops below 60? CPR, right? How do you do CPR in a newborn? 2 fingers or thumb encircling. Newborn CPR really needs to be done 2-person. It does not need to be done 1-person, because you're going to have that positive pressure ventilation with the ambu bag. Then you're also going to have somebody doing chest compressions. What's the ratio? As a neonate or newborn, it is 3-to-1. 3 compressions to 1 ventilation. It is at a rate of 90 to 30. It is 3-to-1. 3-to-1. That is different than just a regular pediatric patient.
3 to 1 is what?
3 to 1 is 90 and 30. 3-to-1. Stimulating them, nasal suctioning, tapping the soles of the feet. We already talked about that. You can do a face mask, non-rebreather, not non-rebreather, but simple face mask, positive pressure ventilation with the ambu bag, or flow by. We put oxygen directly in the baby's face and their eyes. No, why? Can dry them out. What can it cause? What can it do to the eyes, the vision? It can cause blindness. What? Who's the singer? Stevie Ray? Is that right? Stevie Wonder. They said that's how he became blind. Stevie Ray. Well,
Ray Charles.
Ray Charles. That's what I was thinking about. Stevie Wonder. Stevie Ray. They were both to me seem like the same person. Or airways. They might have to have problem. They might have a problem with bilateral coronal atrasia. What is that? Do I know? That's the closing of the nasal passages. There's like a skin flap over the nasal passages. If that skin flap is over the nasal passages, can they breathe? No, because they're nose breathers, right? They're going to have surgery to get that fixed. All right, what about Pierre Robin symptoms? Have you seen any kids like that? I don't know if they have a picture of that in your book or not. These 4 babies look pitiful. I can't remember if there's a picture of that in the book or not. I know there's one in our little book. Their heads are disproportionately shaped. Their eyes are close together. They almost look like a Down syndrome baby with a moon face. That's what they look like. They have a lot of airway abnormalities because their airway is very short. They can also have chronofacial defects, other defects such as cleft palate, cleft lip. Y'all know how to BVN a newborn? Remember that back from basic EMT. We'll have to go through that, do we? If they have a pulse less than 100 beats per minute after stimulation efforts, then they're going to have a little bit of oxygen help. It's going to help increase their heart rate. Intubation, y'all went through intubation last semester with Miss Curry through pediatric intubation. Do you remember that? All right, I think I've got a slide here to show you how to calculate ET tube. I can't remember what it is off the top of my head either, but I've got a slide in here for you. It's either in this one or our peds one. You would need to do intubation if tactile stimulation did not work and their respiratory rate did not increase. Their heart rate did not increase. If you did positive pressure ventilation, that did not help with their heart rate or their respiratory rate. You would have to move into intubation. Equipment, you know what equipment you need. Which blade would you use?
Miller.
Miller? Why Miller?
Because the straight blade
Helps get the epiglottis out of the way. Miller straight blade is best for your infant. Gastric decompression, what do I mean by that? Deflating the stomach, so with a what? NG tube. Why would you need to do that? You're bagging them and it's causing more air to go into the GI area, which is going to cause them to what? Just like your adult patient is going to cause them to vomit, right? If they're not able to maintain a good airway, they're going to aspirate. Chest compressions. Initiate if pulse remains less than 60 after all other efforts are met. Needs to be a 2-person CPR. What is the rate of compressions, ventilations? What is the ratio of compressions to ventilations in a neonate? We just talked about that a few minutes ago. It is 3 to 1. I think somebody's just clicking to be clicking. I need to take these up and see what numbers on the back of them and count as a quiz grade. I think some people are just clicking to be clicking. It is a 3 to 1 ratio, 3 compressions to 1 breath. Y'all know how to do thumb encircling and 2-finger chest compressions. Vascular access. You can access the umbilical vein. I don't know anybody in Alabama that's going to be doing that. I don't know any paramedic really that's going to be accessing an umbilical vein. You can access it that way, and I think your book kind of goes into detail. But when I was talking with Steve and Nick about this, it's not something that is done very often. If you get an IV access, you're going to start an IO or try to get an IV. You're not going to access that umbilical artery or that umbilical vein. That's something they're going to do in the hospital setting. So just know that it can be done, but you're not going to do it. What did you say? Your pharmacological interventions, you're rarely ever going to need to do medicines to a neonate. The main thing with them is to stimulate them and provide flow by oxygen. That's going to be about the most that you need to do for them.
So if they're in cardiac arrest?
Then you would follow the Taos algorithm for that. Freaked you out a little bit, didn't it? All right, so say patients in bradycardia. Their heart rate's low. What's the first thing we're going to do with them? What's the first thing we're going to do? Stimulate them. How are we going to do that? Thump the soles of their feet. Vigorously rub them, warm them up, right? We're going to stimulate them and warm them up. If that doesn't work, what's the next thing we're going to do? Flow by oxygen. If that doesn't work, what are we going to do? Positive pressure ventilation. That doesn't work. We're probably going to start compressions. Yeah, driving really fast. We're going to start compressions. You can also give epinephrine. Epinephrine's the same. First and second dose. You can administer vasopressin if needed. We're going to talk about those doses here in just a few minutes. You can repeat epi every 3 to 5 minutes. What is the dosage for epi on a bradycardia or cardiac arrest neonate? If they're bradycardic or in cardiac arrest, how much epi are they going to get? Sorry. The correct answer is C. 0.01 milligram per kilogram of 1 to 10,000 IV. 0.01. Didn't do my. Let me end that show right there real quick. C, 0.01. All right, low blood volume fluid resuscitation might be needed if they have low circulating blood volume. If they are hypovolemic, they have weak pulses, low pulse rate that's not getting better with chest compression. No improvement in circulatory status after resuscitation efforts with the epinephrine, the CPR. They're going to need a little bit more fluid. How much fluid bolus do neonates get? 10 milliliters per kilogram. Everybody else gets 20. Everybody over the age of 1 gets 20 per kilo. Everybody under the age of 1 gets 10. Make it easy for yourself. Now, how much fluid bolus does a neonate need? I forgot this slide wasn't here next. Sorry. Y'all should all get it right now. We just talked about it. $10. Which fluid do you give them? Isotonic crystalloids, right? Which is saline, lactated ringers. They might need O negative blood, but you're not going to get that field. All right, acidosis. You can suspect if bradycardia persists after adequate ventilation, chest compressions, and volume expansion. They're going to need something to correct the acidosis, and that's not something you're going to do out in the field. You're going to try to resuscitate them as best as possible, monitor their ABCs, and get them to the hospital. Respiratory depression from narcotics. Depending on what medication the mother's been taking, they can get Narcan. It is a very small dose. I think we'll talk about that here in just a few minutes. But in the pre-hospital setting, you're not going to give Narcan to an infant. Why? You can cause more damage than you can good. You're going to cause an infant to go through withdrawals, and that's just not a pretty thing. That's something that needs to be monitored in the NICU. So you're going to give ventilatory support because these patients are going to have poor respiratory depression. So you're going to stimulate them, warm them up, and monitor their airway and transport them immediately. A neonate has respiratory depression from a narcotic administration prior to delivery. What is the dose of Narcan you can give to help with respiratory depression? How much is it? Correct answer is B, 0.1 milligram per kilogram. Narcan, naloxone. You'll see this sometimes given in labor and delivery, like if the mom got Stadol or morphine prior to delivery and the baby came out with poor respiratory rate, they might give them some Narcan. In the pre-hospital setting, you're not going to give it. All right, hypoglycemia. What does hypoglycemia look like in a neonate? Are they going to be confused and disoriented? No. They're not going to be confused and disoriented. They're going to be sluggish or extremely irritable.
Baby, can you tell me what day?
They're going to be screaming, crying. They're not going to be feeding. The most extreme thing they're going to do is start going through some seizures. Obtain good baseline vital signs and a good blood glucose reading. I can't talk today.
Is it the same for neonates or is it different?
No, actually theirs is less than 40 before you treat. That's a good question. Theirs has to be less than 40 deciliters before you treat them. And if you need to treat a neonate, how much dextrose do you give? I didn't mean to get that slide. All right, if the blood glucose is less than 40 milligrams per deciliter, they get 10% of glucose. And the dose for that is 2 milliliters per kilogram. So if they're 5 kilograms, how much are they going to get? 10 milliliters of 10% dextrose, right? How do you make 10% dextrose? Squirt the entire thing of dextrose all the way out to the 10, right? Then you draw the rest of it all the way back up to the 50 with saline. That makes 10% dextrose. Then you would give them 10 milliliters of that 10% solution.
Would you not make it 5 milliliters? Because if it's 50 milliliters and you give them 10, that's really 20 milliliters.
I meant 5, yes, sorry. My math is not good today.
She's on
Thank
the
you.
math. That's why I don't like sitting back there. I take the math quizzes. She's done it in like 2 seconds.
And I always have to go back through and redo them like 10 times because I always make a mistake. Always. Always. Thank you.
I didn't mean to call you out.
No, I'm glad you did. Thank you. You need to do that.
Alright, so what now?
'Cause I'm human. I make mistakes.
Push it down to 5?
Push it down to 5.
Go ahead and do it.
Because it's 50%. So push it down to 5. Because it's not 100%. Because Brady don't know anything today. Brady's been for talking for almost 4 hours. Recheck the level within 30 minutes. Most of the time, these neonates aren't going to be with you anymore, so it's going to be done in the hospital setting. Family and transport conditions. You want to transport to the nearest facility that is appropriate for that patient. You want to take them to a community hospital that they don't have any peds service at all, would you? No, you're not going to be able to help that baby at all. And there's the best facility possible that is compatible with what's going on with them. Transport of a high-risk newborn. I'm not really sure why this is in here for y'all, other than the fact that you might have to do some transports from a hospital to another hospital. Just know, in the hospital setting, if a patient needs to go to another facility, the doctors are the ones that have to make those arrangements. They have to write the orders, and they have to call for an ambulance to transport them. And you would be transporting them, more than likely with help from another nurse to come along with you. I know UAB has their own helicopter, or they have a jet, actually. And they have the Angel One. They have a helicopter, a jet, and an ambulance. They're more than likely going to come get their own babies, if they can. A lot of times they like to come get their own babies instead of somebody else.
They'll come get the really bad ones, but we've taken plenty of them.
Yeah, they'll come get the really, really bad ones. The other ones, you're more likely not going to transfer to neonate to baby.
Most of the time we send an angel one from bad to south comes and gets them, takes them there.
I always hate seeing that ambulance. It's a very pretty ambulance, but it's sad. You guys see those? Conditions that should be treated before leaving a referring hospital, I mean, that's a given. You're not going to let them leave if they've got some problems or complications, and that's the physician responsibility. It's not y'all's responsibility at all. All right, what's apnea? Respiratory pause of greater than 20 seconds. This can happen a lot in newborns. It is common. You just stimulate them, provide flow by oxygen if needed. All right. Pneumothorax evacuation. It's just a needle decompression, just like you would on anybody else. It happens if an infant inhales meconium, the lung is weakened by infection, and it starts to collapse. Where do you do a needle decompression at?
Third, fourth, and third.
I always get that mixed up. The second, third. There's one that's at the second.
The second intercostal space, mid-clavicular line.
It is that?
Right here.
Top of the third, which is the second intercostal space.
Okay, so
That's right.
It's also known as top of the third.
Also, whatever he wants to call it. I call it second intercostal space. He wants to call it top of the third, that's fine. That makes me think it's the third intercostal space. It's second intercostal space, mid-clavicular line.
Third.
That was that test. He didn't make that test up though. He got the ITLS test.
Yeah.
It wasn't his questions.
No, it wasn't his questions at all. She's talking about Nick's test that he gave yesterday. It wasn't his questions. It's the ITLS questions. That's the bad thing about your CPR test, your ACLS test, your PALS test, ITLS. We don't make those questions, and half of them we don't agree with anyway. Y'all remember how to do a needle decompression? We talked about that in advance, or not in advance, excuse me. Talking about that last semester in airway. Do we need to talk about that? I know Nick's going to go over that with you in the lab too. Just make sure that the area is clean. That's the most important thing. Make sure that it's nice and clean. And it's at the second intercostal space or top of the third, whatever you want to call it. Meconium stain amniotic fluid, we already talked about this. The best way to get this cleared up in an infant, they're going, depending on how much meconium is in the amniotic fluid when it comes out. You can tell if it's just slightly tainted, they're probably not going to have suctioning. But if it is a lot of meconium stain in the amniotic fluid, they're going to have to be intubated and suctioned. And the way they do this is they intubate and use a suction, and while they are pulling the tube back out, they're suctioning the entire way coming back out. Does that make sense? They intubate, put down the suction. Suction is they're pulling both the tube and the suction all the way back out because they don't want to leave the baby intubated. Keep them warm, maintain. This is an example of a meconium aspirator. Just hooks on the end of an ET tube. Do you have to carry that on the ambulance? I don't think you do you? You just carry those little French, like 14 or 16 French sections. Those can work too, which is probably what you're going to have to use out in the field if you need to intubate. You're not going to hook a meconium aspiration device up to it and pull the ET tube out, and that'd just be asinine to intubate a baby and then pull it right back out. Of course, take steps to minimize hypothermia. Keep reassessing them every 5 minutes. Monitor their ABCs, stimulate them, warm them up, give them oxygen. Pretty much if the answer is stimulate them and warm them up, that's the first thing you're going to do, right? On every infant and neonate. What's a diaphragmatic hernia?
An abnormal opening.
It's a hernia in the diaphragm, right? It's an abnormal opening to the diaphragm where the stomach intestines go up into the chest cavity. What kind of problems can that cause? Yes. They're not going to breathe correctly. Why? Everything's pressed on the lungs.
And the pressure's going to be off on it.
Blood pressure and stuff's going to be off. Their heart's not going to be able to expand like it needs to. They're going to cause a lot of problems. They're going to need tactile stimulation, and warming is not really going to help them. They're going to have positive pressure ventilation. They're going to have surgery, which is not something that y'all can do. What you can do is monitor their ABCs and transport. This is another example of a premature infant on the right-hand side and a full-term infant on the left-hand side. And they say there's no such thing as an ugly baby, but those are some ugly babies. They are very ugly babies.
That's terrible.
That is terrible. It's true. But it's true. They're not very pretty babies. The one on the left is cuter than the one on the right.
Not his fault, he was born early.
Logan looked a little funky when he came out. I was just like, really? But when Ava came out, she was beautiful. She was very pretty. Alright, we already talked about preterm infants earlier. And the main thing about your preterm infants is they definitely are not able to control their temperature. So you want to keep them warm, keep flow of oxygen handy, kangaroo care with the mom, tackle stimulation. Make sure you keep their airway nice and clear. Seizures. It is the most distinctive sign of a neurological disease. Most seizures in a newborn occur from what?
Temperature rise.
Temperature rise, usually known as febrile seizures. There's rarely an underlying cause, neurological problem that causes seizures. About 80% of them, 85, 90% of them actually are caused from fever. And usually related to female newborns, usually related to UTI. They can have subtle seizures, tonic seizures, focal clonic seizures, and myoclonic seizures. You can read about each of those in your book. Main thing is to keep them safe, provide oxygen, keep them warm, IV access as needed. Their blood glucose is less than 40, and that's why they're having a seizure. You need to try to figure out what the underlying cause of the seizure is. Is it a toxicological problem? Did they get into something that they didn't need to get into? Because somebody just left a pill on the floor and they're scooting around on the floor, moving their head around, they get something in their mouth. It can be deadly to them. They have a fever. They've been given any Tylenol for a fever or Motrin, depending on how old they are. Is it because their blood glucose is low? If it's less than 40, what are they going to need? Dextrose. What's the dose for dextrose? 10% solution, but how much? 2 milliliters per kilogram.
Now, am I supposed to guess how much the baby weighs?
That's what you have Broslo tape for. We're talking about that in pediatrics lecture, I think, too. But that Broslo tape is very beneficial for you to put those kids in that category. This is what color bag you need to grab. The whole bag is useful, yeah.
I wish we had those bags.
You don't have the bags?
We have them, they're not on the trucks. We have Braslo tapes, but that's it.
Yeah.
That's it?
And most of them aren't up to date.
Yeah, they're like from 1993.
You think
There's-
son Joe needs to get something up to date.
Mike Harper said he's ordering some, but the first part of that sentence should be self-explanatory.
All your hypoglycemic patients, ABCs, warm them up, keep them stimulated, and blood glucose less than 40 is going to need glucose. If they're vomiting, it is very common for a newborn or a neonate in the first couple of days of life to vomit. They've got a ton of amniotic fluid still inside, and they will vomit clear fluid for at least the first 24 to 48 hours. My son didn't do that, but Annabelle did. It kind of freaked me out because when she started doing it, I was like, what is wrong with her? Why is she doing that? They're like, oh, that's normal. It happens. I was like, it didn't happen my first one. They do. They will start to vomit for about the first 24 to 48 hours. They'll just open their mouth, and it's almost like they spit up, but it's usually a good bit of clear liquid. Doesn't like breast milk, doesn't like anything other than clear liquid. If it lasts for more than 24 to 48 hours, then you need to also monitor for dehydration. How do you check for dehydration in an infant? Fontanelles. You have one here. What's this one called? Anterior fontanelle. When does it close? 18 months. Okay. Posterior fontanelles back here. When's it close? 6 months. Usually about 6 months of age. The posterior one closes. 18 months when the anterior one closes. And that's how you check to see if they're dehydrated. What's it going to be if they're dehydrated? Sunken in. What's it mean if it's bulging? They're either screaming their head off right then. If you watch them and they're screaming their head off, you can put your hand on the fontanelle and you can feel it bulging. But it also will bulge if they have fluid overload, increasing cranial pressure. Patients can have vomiting for any number of reasons. If it's in the first 24 to 48 hours, it's usually the amniotic fluid. After that, it could be a stomach virus, bacterial infection. It could be pyloric stenosis, which you can see a lot in newborn patients. It could be GERD. Any number of things that can cause problems with vomiting. They can also have malrotation. What's malrotation? Twisting of the intestine. If the intestines get twisted and don't get untwisted, what's going to happen? They can die, right? Just like a testicular torsion and an ovarian torsion. If that torsion does not get fixed, that tissue can die. All right, what about intussusception? What is intussusception? That is when the intestines backs itself up, like it just goes in itself. It backs itself up and goes inside of its own self, meaning the intestines go from one side and go backwards up into itself. It can also cut off circulation to the intestines, and the intestines can die. They're going to have a lot of abdominal pain. They can have vomiting. They're going to be extremely irritable. They have to have surgery for that as well as the malrotation. Vomiting management. Intussusception is best treated also with an NG tube. I highly do not see y'all put in an NG tube in a neonate or a newborn in the field, in an adult, but almost all your pediatric stuff has to be called through medical direction anyway, before you can do anything. But it can be something you can do. This is in your scope of practice. Vomiting, manage their ABCs, keep them warm. They might need fluid resuscitation. If they need fluid resuscitation, the best way to get a fluid bolus in them is probably through what kind of access? IO. You have a really hard time getting IV access on a newborn, right? Especially one who's vomiting and dehydrated. Where are you going to put IO at? The medial aspect of the tibial tuberosity, right? On the medial side, remember? Okay. All right, they can also have diarrhea. They have ugly, nasty looking stool anyway when they're first born. There's that nasty black meconium looking stuff. If they're breastfed babies, well, the good thing about it is it doesn't smell. It doesn't have an odor. Just like breastfed babies, their poop doesn't have an odor. When you start mixing formula and baby poops, then the poop starts stinking. But normal breastfed babies, they have liquid diarrhea poop. That is completely normal. Huh?
Yeah.
It looks like mustard seed.
It does look like mustard seeds. Another reason for diarrhea is poisoning, if it's some kind of bug, GI bug, or lactose intolerance. For babies who are not breastfed, if they are on formula, they start having excessive diarrhea or vomiting, it is because of a lactose intolerance. That's how doctors usually diagnose that. So you might get a call for diarrhea. Main thing you'll get called for with the diarrhea and the vomiting is dehydration. Patient's going to be very tachycardic, hypotensive, sunken fontanelles, poor skin turgor. They're going to need fluids and a bolus of what? 10 per kilo. Manage their ABCs. Where is the best place to assess for hydration in a neonate? Anterior fontanelles. Good job. Neonatal jaundice. A lot of newborns who are born and they're slightly jaundiced. It is completely normal for their bilirubin to be elevated a little bit. Excessive bilirubin elevation is 12 milligrams per deciliter, and this means they are extremely yellow. They'll have yellowing of the sclera, which is the white part in your eye. They're also going to have yellowing of the skin. They're going to have to be put under bilirubin lights and have electrolyte balances checked. They usually check this at birth, then again in the hospital before they leave, and again when they come back for a week checkup through the lactation consultant, they check it again there as well. This for y'all, you need to know that it is normal for newborns to be slightly jaundiced, but if it persists, it is not normal. They've got to get it fixed. It has something to do with liver incompatibility. I can't remember exactly why they become jaundiced. Assessment, transport, that's all you can do. If a mother calls you because their baby's jaundiced, IV access and transport, keep them warm. Thermoregulation, we already talked about that. They are at risk for hypothermia, but they're also at risk for hyperthermia. You have to keep them balanced, well-maintained balance. You can't load them up in the 90-degree weather outside in a parka and a hood and 500 things of clothing on top of them. You're going to cause them to be hyperthermic and they'll start running a fever. Heat loss occurs through evaporation, convection, conduction, and radiation. Remember that back from advanced CMT or even last semester, I think. Fever is anything rectally over 100.4. A rectal temperature is the best temperature to get in a newborn. Now they have those head thermometers. Those things are awesome. I have one of those at home. I love that thing. Never use ear thermometers. They're completely inaccurate. Don't use those. They have a limited ability to control their temperature. They're not going to be able to regulate it. We've already talked about that. So keep them nice and warm, but not too warm. Signs and symptoms of fever. Of course, they're going to be very irritable, crying. They're not difficult to console. Very warm to touch. Examine them for rashes. This is a picture of a rash here. I've also got a picture in your peds lecture of a meningitis rash. It's like very purplish, patchy rash. Some neonates can just get a virus. Newborns, they'll get a virus, or neonates, excuse me, they'll get a virus, fever, and they'll run up, developing this rash all over. The main thing you do for those is just keep them monitor their ABCs, transport them to the hospital. I'm so ready to be done. I know y'all are too, aren't you?
We got another shot.
All right, in order to keep them nice and cool, do you dip them in alcohol or put them in a cold bath? How do you keep them nice and cold? Or nice and cool? Get them cool if they're running fever.
Dip them in alcohol.
Rubbing alcohol is what I'm talking about.
I've never heard that.
They used to tell you, old wives' tale is rub rubbing alcohol on them and let it evaporate, and it will help take the fever away. That actually can make them toxic and drunk. And another thing too, for people like, especially those who like huff alcohol, it's acetone. It builds up acetone in their bloodstream, in their liver, and causes liver damage and kidney damage. But you remove the clothing from them. You leave them in their diaper, remove everything else to keep them nice and cool to help promote fever reduction. We're talking about hypothermia. I'm not going to talk about hypothermia again. We just wrote 10 times. Common birth injuries in newborns. We talked about this a little bit earlier. Skull fractures, especially from precipitous deliveries. Cephalohematoma, which is just a hematoma on the scalp. Kaput, I can't say that word, swelling the scalp that disappears. All these things can also be caused by devices used to deliver a baby, such as the vacuum seal or forceps delivery. They don't use either one of those very much anymore because they've had a lot of problems and complications, and they cause brain injuries, cervical spine injuries. You don't want any of that. Brachial plexus injury we talked about earlier, where their shoulder winds up getting broke and that brachial nerve gets severed that cannot ever be fixed, and they lose complete loss of sensation and motor ability in that left or right arm. Facial nerve palsy, same thing, just like it would be for brachial plexus. That facial nerve is messed up from forceps injury. They wind up losing sensation in their face. That's what happened to Sylvester Stallone. He was a forceps delivery. That's why his face isn't like that, just because he didn't have a stroke or anything. It happened at birth.
I thought it was all those courses he took.
No, it actually was a birth defect, a birth injury from forceps delivery. They can also have very severe spinal cord injury, especially for those physicians who want to pull on the head and the neck.
And I was saying, man, what the hell did? And he was sitting there rubbing it. I was like, oh. You gotta rub it right.
Yeah, you do. Rubbing it right will keep you pregnant.
Clavicle can also be broken, especially if you got a shoulder dystocia. Your clavicle can be broken in an infant or neonate, excuse me. Long bone fractures can be present due to a spontaneous delivery, or if the baby gets dropped, they can have a long bone injury. Intra-abdominal injury is very uncommon. Hypoxia and shock can be caused by birth trauma as well. There are several different congenital heart defects. We're going to talk about each of those just a little bit. Pulmonary stenosis is stenosis of the pulmonic valve. Patient can present with jugular vein distension, cyanosis, right ventricular hypertrophy. What are you going to do for these patients?
Rapid transport.
ABCs, rapid transport. All right, your septal defects. You have your atrial septal defect. So deoxygenated blood can shift from the right or left atrium. So is this good or bad?
Bad.
Bad, right? It's mixing with the blood. So they're not getting oxygenated blood where it needs to be. I also have a ventricular septal defect, which is the ventricular area, same thing. Wishy-washy in the blood. Monitor their ABCs, stimulate them, keep them warm. These patients are probably going to need positive pressure ventilation because we're going to have mixed matched blood going through. You have patent ductus arteriosus, which is not closed after birth. Can cause congestive heart failure if it's left untreated. All these things are surgical, have to have surgical interventions. It's nothing that you can do in the pre-hospital setting. Just know what they are is really about the only thing you can do. And transport them. Everybody needs ABCs and transport. Coarctation of the aorta is just narrowing of the aorta. What's the aorta do? Ties the body with blood. If it's narrowed, is the body getting as much blood as it needs to? No. And if the heart is forcefully pushing that blood through the aorta, what's going to happen to it? It can burst, right? It can get tired, it can burst, it can get a tear. And that's also going to cause left ventricular hypertrophy, right? Because left ventricle is the one pushing it out through the aorta. And if it's having to work extra hard to push the blood out through a very thin pipe, you're going to have a hard heart muscle. That heart muscle is going to be hypertrophic because it's going to be working way harder than it needs to. Truncus arteriosus requires surgical intervention. This is the pulmonary and aortic arteries are combined. So if the pulmonary and aortic arteries are combined, what's happening? Wishy-washy of blood, right? Because the pulmonary artery takes deoxygenated blood to the lungs. Veins are the ones that bring it back. Artery takes oxygenated blood to the body. So if they're wishy-washy and back and forth, then your body's getting oxygenated blood and deoxygenated blood rotating all the way around. They're going to have poor oxygen level or good oxygen level? Poor. They're going to be hypoxic. They're going to need oxygen. Tricuspid atresia is just the tricuspid area is closed off. Decreased blood flow to the lungs, which causes a decreased blood flow of oxygenated blood to the body. They're going to be hypoxic, monitor their ABCs. Hyperplastic left heart syndrome. The left heart is completely underdeveloped. And what's the left side of the heart do? Pumps the oxygenated blood through the body, right? If that's underdeveloped, is it going to pump enough oxygenated blood to the body? No. They're going to become hypoxic again. Tetralogy of flow, what is that? They have like 3 or 4 different atrial ventricular septal defects, and it causes a complete wishy-washy in the blood. These patients are going to have open heart surgery immediately after birth. And they can tell this in utero in an ultrasound. Transposition of the great vessels. The blood goes through the lungs and returns to the lungs. Blood from the body goes back to the body. The arteries are not where they need to be. So instead of it going to the lungs and coming back to the heart and then going to the body's keeping its deoxygenated blood and the lungs are keeping its oxygenated blood. So everything is back and forth. He's like, I can't take it anymore. I gotta get out of here. Total amniomeless pulmonary venous return. That is horrible. I can't even say anything. It's horrible. Horrible.
2 more slides.
Oh, is that it? Really?
Yeah.
I don't even know what slide we're on. Okay.
104 and 106.
The 4 pulmonary veins connect to the right atrium instead of the left atrium. Why would that be problematic? If it's going to the right atrium, where does the right atrium blood go to? The right ventricle. Where's the right ventricle blood go to? To the lungs. If the pulmonary veins are what bring the oxygenated blood back to the left atrium, if it's not going to the left atrium, it's going back to the right atrium, we're just constantly oxygenating that blood, right? Yep. Is that oxygenated blood getting into circulation anywhere? No. No. Baby going to die? Yep. What are you going to have to do for them? They're going to need surgery, right? ABCs. ABCs, ABCs, ABCs. All these cardiac conditions, the main thing for them is monitor their ABCs, positive pressure ventilation, transport to the hospital. Yay!
Why did no one ever teach me this?
Teach you what?
I'm gonna write this up.
You just now learned that?
Wow.
Maybe you know what's going on.
All right, you want to take 10 minutes and we'll start on the peds?
No.
How many of you want to go home?
Holy cow.
We have to do it again anyway.
I'm not here anyway.
Y'all are really not here, are you? Are you going to learn anything?
No.
I'm sorry.
It's not your fault.
Is that horrible? No, it's horrible today, believe me.